एक सेकंड।
नहीं भाई,
No need to close.
ठीक है ये भाई।
इनको बता दो
Virtual
करेंगे ना
background,
तो
you know.
शेयर स्क्रीन के अंदर प्लीज ऑडियो सिलेक्ट करें नीचे से, शेयर विथ ऑडियो, क्योंकि हर प्रेजेंटेशन में वो लोग चेंज करेंगे ना डॉक्टर के।
हाँ हाँ, वो लड़के को पता है। Dear, when you share a presentation, you will share with the audio, right? Yeah. He knows the भाई. He's well known about that actually.
Just now we did no with audio.
Yeah,
we share.
with audio. He
Why
will
again?
share.
काम अच्छा, ये हो गया तेरा YouTube का लिंक, ठीक है? ये YouTube का दिया मैंने, और अभी एक बार वेबिनार के भी वापस दे देता हूँ लिंक। वेबिनार का लिंक जो डे 1 पे डालना है ना, फ्राइडे पे, वो बटन पे
Coming black only.
Zoom का।
तो ये भाई, how did you put your profile
एक मिनट।
picture? Can you please guide Tiger?
पहले है
Zoom का
ना,
लिंक होगा।
जूम के ऊपर
Share screen maybe stop. You want to
Zoom,
stop?
click on the Zoom, not on the webinar, on the
No,
Zoom.
share screen going on. Huh? Only 3 minutes left. No time.
You need to put that.
हाँ नहीं भाई,
तो ये भाई मोस्ट इम्पोर्टेंट, आपने ये जो प्रोफाइल पिक्चर लगाई है अपनी, ये कैसे लगाई है? हमने वो पोडियम पे लगाई
बताता हूँ ना, देखो जूम के अंदर जाओ, जहाँ से हम लोग मीटिंग कनेक्ट करते हैं ना, वो वाला ब्राउजर पे।
ओके, ये Zoom का लिंक मैंने दिया तेरे को आज का।
इंग्लिश। तो ये भाई इंग्लिश।
ये रहा।
टाइगर
ये दोनों अपडेट कर दे, चलो ऊपर, और पहले 360 की फाइल अपडेट कर दे,
जूम ऐप,
और फिर ये Zoom की लिंक, YouTube की लिंक, और वो मैसेज ऊपर, ठीक है?
there is on the right hand side,
हो गया, मुझे बता।
you will see your profile.
No.
Zoom, not on the Zoom screen, not on your screen where webinar is working. Minimize.
sign in.
Sign in again. I want to do sign in.
No,
Yes.
No, not here.
Open this. Close.
Then I want to close this meeting.
Yes, no, don't close the meeting.
Then
Keep this. Come here. Yeah, there is. No.
this is the
Edit
Zoom.
profile. There is a
No, now we cannot do Sayyid bhai because running time. So the video. How it will be? Yeah.
उसको मेरे को share screen
No,
करो।
not happening here. The presentation starts.
Okay, leave it about podium.
चलो स्टार्ट करो। मैं ईमेल मोकली हो जाता है ना, ईमेल।
तो ये भी छोड़े podium black रहने।
ओके मुस्ता भाई,
मैं ईमेल मोकली हो से बताना है।
ओके मुस्ता भाई,
वी आर रेडी।
ચાલો મુસ્તા ભાઈ, मैं पहलो प्रेजेंटेशन નો આ લગાવું છું, નહીં જાસીમ નો પહેલો જાસીમ નો છે ને ટોપિક, એ મેં લગાવું છું, અને પછી
આયા નથી,
मैं પછી म्यूट કરી દઈશ अपना अपना।
હા, બધાને મ્યુટ જ રાખવાનું છે, એવરીબોડી હેઝ ટુ બી મ્યુટ, ખાલી પોડિયમ ચાલશે।
You have to share screen. You will give this one. You will share.
How we can do this one? No, not share screen. The background man. Sign in. We cannot.
We are going to start.
મુસ્તા
The phone.
મુસ્તા ભાઈ સ્ક્રીન જોવાય છે ને હવે જાસીમ ની?
એક મિનિટ, મેં છે ને ઈમેલ મોકલી રહ્યો છે। હા, જોવાય છે। યસ,
હા ઓકે।
આપણે મ્યુટ કરી દો બધા। હવે એ લોકો આયા નથી શું હોટલમાં હજી તક?
નહીં યાર, આયા નથી લાગે છે, જોવાતા નહીં, ખાલી જ જોવાય છે। હા, આવી ગયો છે, આ કોણ આવ્યો છે? આવી ગયો
આ તો એસર શબ્દ।
ઓકે, આવી ગયા, मैं म्यूट કરું છું। ઓકે, હવે
Now start. Nine.
No.
Start.
Wait. Share screen, come here. Yes. And we come here.
Stop.
Share. Now you choose what you want.
What is
Desktop. Come here.
what the file now? Check.
ઈમેલ મોકલી દીધા।
Taking this one.
You are in practice session. Practice session.
You can open the other presentation also. Well, no need. But we should know which one.
It's the presentation, no?
This is the current one. Just open the fifth you can see.
Fifth slide? Fifth slide?
The folder. No. First slide.
It's already shared.
Okay. Where is Pare? This one. Wait. This is
No. Nothing.
Should I start the webinar? Let me know. Huh?
What is this one?
वेबिनार करे स्टार्ट करूँ तो मैंने क्या एग्जैक्टली है
This one? Huh?
You are in practice session. Okay.
Right. Single, no? Done.
ये अपना हमारा पास नहीं है. We don't have this.
Are you ready?
Should I start the webinar?
Or
Mute होगा भाई. Can I start the webinar?
tell me when it is ready to go.
જો સ્પીકર ઓન છે અને તમે હોસ્ટ છો એ બધું જરા ચેક કરી લો.
Of course.
મુસા ભાઈ
Yes.
ઓટોમેટિક ના ઉપર એક બ્લેક કલર ની પટ્ટી જોવાય છે
હા પટ્ટી જોવાય છે. Yes.
એ ડિઝાઇન માં છે એવી
મને નહીં ખબર હવે મને શું ખબર કોનો પ્રેઝન્ટેશન છે ડોક્ટર જાસિમ નો છે ને પ્રેઝન્ટેશન.
एक सेकंड साद साद हेलो साद साद डॉक्टर के प्रेजेंटेशन के पास में जाओ और नेक्स्ट स्लाइड करो स्लाइड 2 और वापस स्लाइड 1 करो तो
એક પટ્ટી આવી જ રહી છે કન્ટિન્યુઅસ. હવે ઉપર બી પટ્ટી આવી કોઈ ટાઈપનો લેગ છે આ. પ્રેઝન્ટેશન આવી રહ્યું છે તે વાત આખું મેસ છે પૂરું.
Creating the practice session.
जिन्होंने who created the practice session.
He is the creator. He won't remove it.
इसी की वजह से आपको स्टॉप हो गया. अभी इसको क्लोज करके वापस से चालू करो. It's coming. We have to close and open.
He needs to create new one.
Who wanted to do it?
The host.
Give my problem.
Okay, just open it now. We go on with this one. And after we finish it, then we can change.
This one, no?
What is working? What is working?
Yes, done. we on? Are we on now?
شنو قاعد يبين؟ اشتغل؟ ريفرش شو في احد
If they want to join now, they can join start. If they want to join also. And then you forward them. What's the email?
They're already late. Where's the badge? Where's the badge above?
There's a link, right?
Above automatic not there.
इनको बोलो मुझे नहीं पता इन्होंने वेबसाइट में अपडेट किया है।
Doctor.
Again, now I want to share. Okay, going share. Where automatic? This. Okay, there is advanced files. Okay, I click this one. There is no automatic. I clicked. I give share. Okay, done. Done. Then. They are, but how I can remove this? I'm
Just you
not.
have to close.
I closed on this. Stop sharing.
Okay.
Okay.
Close here from here. We have to do again. Leave webinar and again we have to come.
Now again join meeting.
Yeah. You have no control V. You have it no.
What where is it? Doctor shouting.
Why you waited till this
No,
moment
this
till
all-
you go live? Why you didn't go live from before the time?
We were live. We were live always.
Take the phone. No. Where is this one? Podium, where podium? This one. Fine. Tell him it's not going. It's not going. Yeah, right.
Webinar has started now.
It's not going.
यार तुम बातें वो अपने को कर रहा है यार ठीक है make it live it's webinar is live yeah
Single duplicate. Okay. Yes, doctor.
Live,
Yes,
live
sir.
is fine.
Yes, doctor.
the first slide.
I don't know why you did this. Just move your hand. So it's working now. So good morning, everyone. I would like to welcome you to the 5th Kuwait Neurology Conference. My name is Dr. Jassim Al-Hashir. I'm the president of Kuwait Neurological Society and the chair of this conference. It gives me a great pleasure to have all of you attending this event virtually due to this pandemic. Over the past 10 years, we have been conducting this Kuwait Neurology Conference with international speakers. But due to the pandemic, we came with many challenges to do this event with our esteemed speakers from Kuwait. And hopefully, everyone will be enjoying these 2 days of brief coverage of different neurological disorders. This is a CME accredited event. And also I would like to thank all the organizing committee and our speakers to put their time to do these presentations during this challenging time and to attend also physically. This is first of its kind in Kuwait to do a hybrid meeting, including physical attendance of the speakers and also online on the same time. I do understand the technology glitches and some difficulties. So I do also appreciate your patience with us in case you face any technology delay. This presentation will be on demand as well in 2 weeks after the events. So without further ado, I will start the meeting, and the first session is the headache sessions, and my presentation is the first one. I'm a consultant neurologist. I'm a headache specialist. I work at Ibn Sina Hospital, and I'm an associate professor at the Kuwait University. So, trigeminal autonomic cephalalgia includes 4 types of headache. The first one is a cluster headache, and also paroxysmal hemicrania, suna, and hemicrania continua. We'll start first with cluster headache. The lifetime prevalence of cluster headache is around 124 per 100,000. This is as much as multiple sclerosis in the UK. We know that the prevalence of this is mainly affecting male, and they are usually smoker. So we do see female as well. The prevalence has been said also it's equally probably affected in male and female in the Western country due to the smoking that is probably common among even females. Episodic cluster is way common than chronic cluster headache, and it's about 6-to-1. To define episodic cluster headache, you have to have 2 episodes of a cluster lasting from 1 week up to 1 year, and there should be a separation of 3 months. You have to know that this has been done in the latest classification of the headache disorder, 3rd edition. Previously, we thought it's 1 month, but 1 month is not enough time to separate between the episodic and chronic cluster headache. So remember the rule of 3 months separation without a treatment. If there is a 3 months off without a treatment, then this is actually either you define it as episodic or cluster. It's not 1 month anymore. The autonomic feature you will see, the commonest autonomic feature is lacrimation. We do see
autonomic features in migraine patients in about 30 to 40% as well. Now, photophobia also can be seen in the patients with cluster headache. So in about 50% of patients with cluster headache, we do see also their photophobia. Interestingly, the photophobia in a patient with a cluster headache is usually unilateral. This is unlike what we see in a migraine patient where it is bilateral. So the commonest manifestation is lacrimation, conjunctival injection, and then the nasal symptom, which could be either congestions or runny nose. This is an interesting article published this year, and it has been done based on an internet survey and in the US, and they found it has been conducted over 1,000 of people with a cluster headache. And in more than 1,000 of people, of patients who has cluster headache, when they were asked about their pain experience, they rated the cluster headache as this one of the worst. And even in a female, they say that this is even worse than the labor pain. So in a numerical scale, it came as 9.7. This is just to give you an idea. When a patient with a cluster headache come to you to the clinic and they cry with the tears and congestion in the nose, or they throw themselves. So this is true. They are really in severe pain. The cranial autonomic symptoms we are referring to in these patients with autonomic or trigeminal autonomic cephalalgia includes conjunctival injection, tearing, nasal congestion or runny nose, eyelid edema. They can have facial swelling or sweating. One of the symptoms that we do recognize also is the fullness in the ear. So fullness in the ears, this is again something you will see, and many of the cluster patients, they will tell you that we feel fullness in their ear. The ptosis and the meiosis also sometimes can't be seen. You can ask your patients. Some of your patients will actually picture themselves to see their ptosis. Cluster headache, based on the International Classification of Headache Disorder, the latest edition, which is the 3rd edition, should have more than 5 attacks. Classical teaching, and this is a very, very important note that you have to know, that the shorter is the name, is the longer the attack. So cluster headache is the shortest name, but it does have the longest attack. So the attack is between 15 to 180 minutes. Now, short SUNT headache, which is short-lasting unilateral neuralgiform headache with conjunctival injection and tearing, although it's the longest name, but it has the shortest attack between 1 to 600 seconds. So the headache should have one of the following symptoms. It's either the C and 1 or 2 or one of them. So as I said, the autonomic features, plus one of the very important features of cluster headache, that they will have restlessness, pacing. We say that they cannot stay still. This is unlike migraine patient, where they prefer to stay in a quiet room and they hate to move, because one of the features also of migraine, that actually the pain can be exacerbated with movement. They can have the frequency either 1 every other day to 8 attacks per day. And as I say, to differentiate between episodic and chronic, it should be 3 months in between without the treatment. There is a phenomena which is involved in patients with trigeminal autonomic cephalalgia, which is the periodicity. Periodicity we refer to circadian or circannual. The circannual, that's mean the clustering of the attacks during specific months. And that's what we see. Most of the patients actually, they do cluster during the October, November, and January. And that's what we see also, what we have been seeing in Kuwait as well. We published this in 2019, that majority of our patients come during October. The circadian is actually, again, due to the hypothalamus. It's actually most of the attacks happen during 2 or 3 a.m. And that's what your patient will tell you about this. Now, that's what we have published in Frontier in Neurology in our study that we conducted between 2016 and 2018. Over 46 patients, the 3 of them were female only. Interestingly, the 3 of them were smokers. One of the interesting phenomena as well, when people try to quit smoking, actually cluster headache become less frequent in these patients. So the majority, again, and 50% of these patients, they do have 1 cluster or 1 episode per year. Some of them, they do have more than attacks per year, and some of them, they will have an attack every 2 or 3 years. The majority or 100% of them, they did have rhinorrhea and nasal congestion, and 97% they did have lacrimation. So what shall we do with those patients? The first thing actually, I do tell my resident and even my colleagues is actually to review the diagnosis, because these patients can be misdiagnosed as migraine, but in reality is actually they are cluster, or some people, they can diagnose them with a cluster, but in fact they are migraine. So review their diagnosis. Female gender should not stop you from diagnosing these patients that they have a cluster headache. Even if they don't, we start to see even non-smoker patients actually, they do have cluster headache. The level A evidence for this patient is for sub-Q imigran or sumatriptan. You can give up to 2 injections. Each injection is 6 milligram. You can give nasal spray of sumatriptan, 20 milligram. Zolmitriptan or Zomig, you can give these patients actually, but remember, the majority of the country, they have 2.5, so they go up to 2 tablets of Zolmitriptan or Zomig. Well, I don't have actually here the nasal spray of DHE, which is another thing that you can give those patients. 100% of oxygen, that's the quickest thing, and you can have it available in the polyclinic. So I usually provide my patient with a piece of paper. So they should go to high flow with a facial mask. It's not a nasal prong, and it should run from 12 to 15 minutes. Remember that these patients usually that they are smokers. So when you provide them with a cylinder of oxygen, you have to warn them that with the smoking that can cause actually fire, and that something very serious can happen. So you have to warn your patient about smoking with a cylinder gas around. Now, the other thing, the level 2 evidence is actually intranasal lidocaine. I don't use a lot of this, but there is a lot of people that are using as phenocath lidocaine. There is no great evidence about intranasal lidocaine. With the drawback of this is actually many people of cluster headache, they do have nasal congestion. And when they do have a nasal congestion, actually you will decrease the absorption from the nasal mucosa for the intranasal lidocaine. Some of the people, they say you can put the intranasal lidocaine in the ipsilateral side of the cluster headache, but we found that this is not typically correlated actually where you find this in the brain or in the hypothalamus. Now, DHE or dihydroergotamine, we have it available as an ampoule. This is 1 milligram. So you can give this as an IV actually, or as an in Kuwait. Level 2 evidence also for non-invasive vagal nerve stimulator, but the evidence is only for episodic cluster. It's not significant for chronic cluster patients. So what limitation we do have with the management? The triptans, you cannot use more than 2 times. Some of the patients, they have more than 2 attacks. So what shall we do? The other thing, we cannot combine DHE with the triptans because of the vasoconstriction. It's not always in 100% patients actually, they will respond to the oxygen. It's only 70 to 80% of the patient, they do respond to the oxygen. So what shall we do with the other patients? And you have to remember also that these patients actually in their 50s and 60s, so they may have ischemic heart disease or uncontrolled hypertension. So using these DHE compounds or triptans put you at risk of the patient actually vasoconstriction in these patients. What shall we do for prevention? So you can use a prevention for even episodic cluster when they are frequent, or if the patient will have 1 attack per year, you can use just a short course and you wait and see. But if they have more than frequent attacks, so you can start them in a prevention. For short-term or transitional or bridging therapy, you can do greater occipital nerve injection. I do many of the greater occipital nerve injection. So what we use dipomedrol, 40 milligram or 80 milligram, and we mix this with lidocaine, about 2 to 3 cc. The group in Paris, Leroux group, published in Lancet Neurology in 2011, they mentioned actually that repeated injection of greater occipital nerves actually was beneficial, and you can do these repeated injection over 48 to 72 hours with no harm in a patient with episodic or chronic cluster headache, despite they have been on verapamil. You can use a short actually course of prednisolone over 16 or 18 or 21 days, and you just go tapering dose. I usually go to 80 milligram unless the patient weight is below 60 milligram. You can use DHE 1 milligram every 8 hours, and you can go for a few days with this. Now, the long term, the best evidence for long term is for verapamil. And you have to know that verapamil is a calcium channel blocker. So each patient you're going to start verapamil, you have to do a baseline ECG. The best evidence for verapamil is for short lasting, actually, for the immediate release verapamil, not for the sustained release. The majority of the people, they do use sustained release, but that because of the erratic absorption for sustained release, we don't know exactly what is the lifetime or the biomedical availability of this sustained release verapamil. So it's better to go with 80 milligram TDS to start, and then you can titrate the dose every 2 weeks, and you have to repeat your ECG. One of the things actually interesting with verapamil, you may find it's not a dose dependent arrhythmia. So you may find arrhythmia even with a low dose, and you may don't find arrhythmia at the beginning of the starting the dose, but later in the disease, you may find an arrhythmia people with verapamil. So ECG is very important. You have to always check their pulses. Other thing is non-invasive vagal nerve stimulation, and the evidence based on the ACT-1 and ACT-2 trial is significant only for episodic cluster, not for chronic cluster headache. The other thing for prevention is melatonin, topiramate. There is some evidence for botulinum toxin injection. And as I said, also for non-invasive vagal nerve stimulation, with invasion is actually you can use phenopalatine ganglion stimulation. Unfortunately, although the evidence is good and is significant, but the company went bankruptcy actually in the last 2 years. So that's very unfortunate for this company. I don't know in the coming year with this pandemic what will happen with the sphenopalatine ganglion. I believe that the sphenopalatine ganglion stimulation is way better than sphenocath actually lidocaine injection, because that will give only a temporary actually improvement in the patient with a cluster headache. So greater occipital nerve block, you just identify the posterior occipital protuberance or the anion and your mastoid process. You go midway over this. Sometimes I do block the third occipital nerve. They usually in the middle is the greater occipital, and if you go actually more lateral, you may even block the greater auricular nerve. You have to look for the occipital artery. So you have to be always worried about occipital artery. Just do some aspiration and make sure you are not in a vessel. One of the complications is the alopecia. I have never experienced actual alopecia in my patient, but actually the local discomfort is common. Some of the literature actually said even if the patient has tenderness, or if the patient has tenderness, or they have discomfort with the injection, that may indicate actually improvement. So I just tell them, wait, that's probably a good sign that the headache will disappear. Okay, so I spoke about constipation with the verapamil and actually the arrhythmia. So the total number of the arrhythmia actually based on Cohen group is actually around 20%, the total number of arrhythmia. First degree block is the commonest one. Now, this is a non-invasive vagal stimulator. This is the old version. This is the newer version of the gamma core for non-invasive vagal nerve stimulator. As I said, this is evidence for only episodic, not chronic cluster patient. You can use it as a prevention or during even the acute attack. And it has been actually shown superiority, significant superiority actually to the sham procedures. This is the sphenopalatine ganglion stimulation. You insert the stimulator and you can actually, there is a monitor for this and you can program it, but unfortunately the company went to actually bankruptcy, so I will not go further into this. The emerging therapy, which is an excellent therapy, that's what stopped us actually. If you remember 10 years ago, people, they were talking about deep brain stimulation, posterior hypothalamus deep brain stimulation, but we think this is invasive procedures, and with the availability of the treatment now, especially with galcanezumab now, is actually you can stop the patient from having severe attacks. The evidence for galcanezumab or Emgality is a 300 milligram, and it comes actually in 3 pre-filled syringes. Each syringe is 100 milligram. You will inject each injection separately in a different site. So there is an evidence came and the FDA approved this actually for a patient with, again, episodic cluster headache, not a chronic cluster headache. I don't know. There is probably something specific about chronic cluster headache. It could be the CGRP level in these patients, or it could be there is another neurotransmitter actually playing in this patient. That's why probably non-invasive vagal nerve stimulator and the galcanezumab only working in a patient with episodic, not a chronic cluster headache. I'll switch gears now to paroxysmal hemicrania, which is much less common. Remember that the commonest one from the TACs or trigeminal autonomic cephalalgia is a cluster headache. The paroxysmal hemicrania is probably equally affecting male and female. And the chronic paroxysmal hemicrania is more common than the episodic paroxysmal hemicrania. So they should have 20 attacks. It's 2 to 30 minutes. Actually, they have autonomic features, but there is a specific thing actually about paroxysmal hemicrania, and it's the pain is absolutely actually prevented by indomethacin. So usually we start the patient with 25 milligram 3 times a day. You can bump the dose. The maximum dose is 225 milligram. In the literature, there are some people actually went above 225, but we don't really advise this because of the gastric complaint. Now, some of the centers, they do have indomethacin available as an IV preparation, and you can go over 100 to 200 milligram, and you can try this actually as an inpatient in some of the patients, then you can switch them. You just want to prove that this headache actually, to prove that this headache is responsive to indomethacin. The chronic type of paroxysmal hemicrania, as I said, is more common, and it's actually it's more in a female. Remember, the rule of 3 months is actually that's how you define between episodic and chronic. If you have 3 months without any attacks, so that's chronic paroxysmal hemicrania. That's a chronic cluster. So the rule of 3 months again. Now, sometimes sooner. That's a very rare headache. Short-lasting unilateral neurology form headache with conjunctival injection and tearing, or short-lasting unilateral neurology form headache with autonomic manifestation. They do have, the main thing is actually in SUNA, only one or neither of conjunctival injection or lacrimation, but the headache, they look the same. The headache is very bad, is actually it's moderate to severe, and usually those are side-look. One of the important information, we think that cluster is only strictly unilateral, but there is actually many cases report about patients with a cluster that they switch places. Same things actually, I hate, or many people actually, they had that they see the migraine only in one side and they don't switch. But in the literature, again, there has been migraine, which is strictly unilateral in such patients. The instant actually will have the duration. Remember, in the second edition, it was 5 to 240 seconds. This has been changed actually to 1 second to 600 seconds. So they can have a group of stabs actually in a total duration of 10 to 1,200 seconds, and they can go with like a sawtooth pattern. Actually, they have multiple attacks or stabs actually of pain. This pain is actually not triggable. It's a triggable. This is unlike trigeminal neuralgia. So in trigeminal neuralgia, you will have a refractory period. So the main differential actually between SUNT is actually the trigeminal neuralgia. Two features actually can help you to differentiate the two. The refractory period, which you will have in trigeminal neuralgia, where people, they don't have pain, and during this time, they can shave, they can eat, they can brush their teeth. But actually in SUN, this is actually in 80% is triggable, with usually with a cutaneous touching or stimulation. In SUNT, also you have to do, actually, in all TACs, trigeminal autonomic cephalalgia, you have to do MRI brain looking specifically for the suprasellar region. 10% of the patient with TACs, they do have actually suprasellar lesion, and usually it's a prolactinoma. Usually the reason is actually because the suprasellar region is touching the hypothalamus. And this is where we say it's the periodicity, because of something happening at the level of the hypothalamus, which gives you the periodicity. Is it due to the prolactin itself? We are not sure. One of the best treatment, and the first treatment you should try with a patient with SUN, is actually lamotrigine. So lamotrigine, actually, I have 3 or 4 patients actually, 2 of them male and the other 2 is actually female, and all of them actually responded nicely to Lamictal or lamotrigine. Hemicrania continua, this is the last one. It's a continuous headache. It's a continuous headache, moderate to severe, side lock with more than 3 months. It has to be more than it has to be continuous more than 3 months. It has the autonomic features, and that's another headache actually, which is completely prevented by indomethacin. So it's prevented. The other way of managing this patient is actually also other COX-2 inhibitor, other non-steroidal. You can use COX-2 also inhibitors in these patients, but many of these patients actually, they respond to greater nerve block. So many of them actually, they don't need to be in indomethacin actually, but they need to be on repeated injection of greater occipital nerve block. One of the criteria which will be introduced maybe to the new classification which come, or when there will be an addition to the international classification of headache disorder, they classified this and chronic hemicrania continue as remitting or unremitting. So the remitting type, if you have 24 hours without any pain, or unremitting type, if you don't have any 24 hours. If you have 24 hours with no pain, we will call this remitting type of hemicrania continua. But you have to know that hemicrania continua always run on a certain level of pain, then they will have pain, but they don't go to the 0 level. This is my last slide. So I just put this to wrap up this presentation to differentiate between the most important 3 types of trigeminal autonomic cephalalgia, the cluster, the paroxysmal hemicrania, and the SUNT and the SUNA. You have to know that in cluster mainly it's male, but you can see this in a female, and you have to know the number of the attacks and the duration. As we say, the longer is the name, the longer is the name, the shorter is the attack, as you see in SUNT and SUNA. And actually, you have to know the autonomic feature, which are very prominent in patients with SUNT and SUNA, and the migrainous feature. You can have this, even migrainous features and photophobia. You can see it in a patient with hemicrania continua. Alcohol is well-known trigger to the patient with cluster headache, but we know that the alcohol triggered the people during the attack. So it's when they are not during the attack, usually alcohol is not triggering their attack of cluster, but during the attack is actually the people, they can trigger their migraine. This is based on many actually publications. The cutaneous trigger is really a feature of patient with SUNT and SUNA, but not features of other patients with it's not a feature of the other trigeminal autonomic cephalalgia. I just came to remember that the 2 things actually differentiate between SUNT and SUNA, between SUNT and trigeminal neuralgia is actually the first one is the refractory period, which you'll find at trigeminal neuralgia, and also response to carbamazepine. So Tegretol, usually patient with trigeminal neuralgia, not patient with SUNT. These are the 2 features. So that's the end of my presentation. Now, our next speaker will be Dr. Khalifa Al-Shaiji. Dr. Khalifa Al-Shaiji is a neurologist at Jaber Al-Ahmed Hospital. He did his medical school in Kuwait, and he is a graduate of the Kuwait Neurology program. He's one of the excellent speakers and one of the excellent actually neurologists in Kuwait. And Dr. Khalifa will talk to us about update and management of migraine. So with that, I'll leave the floor for Dr. Khalifa.
Switch my internet. Where's next? So, this is so, update and then this one. Okay, to switch slide. Okay, just to so tell me when to start. Okay, let's start. Okay, good morning, everyone. Today, I'm going to talk about the update in the management of migraine that's happened in the past few years. I'll try to cover as much as I can regarding the new era of the management of migraine. So these are the objective of my talk. We know that migraine is one of the most commonly encountered neurological complaint in our practice. It's classified as episodic or chronic, and each type further subdivided depending whether they contain aura or not. It's more prevalent in female, and around 90% of patients have a positive family history. And usually the big prevalence between the age of 35 to 39. Migraine is a leading cause of disability. And this fact was well demonstrated through the global burden of disease study in 2016, where it comes next to the back pain. So almost affects all aspects of the life. And despite this, it is still under-recognized and under-treated. And this also have been shown in this study that have been done by Dr. Al-Hashil in Kuwait, where they tried to find the migraine burden in Kuwait through a cross-sectional study, which include around 15,000 patients. And the 1 year prevalence of migraine was 23%, which is a bit high when compared to countries in our region. Most of the patients who was labeled as having migraine through the survey seek medical help. Only 17% of them seen by a neurologist. Moreover, only 4.6% receive an official diagnosis of migraine. And this confirmed the fact that migraine is still underdiagnosed, and therefore there will be low or mistreatment or undertreatment of these patients. These are the general recommendation of subset of patients who need preventive treatment. However, as a general, you should balance between the frequency of the attack and the migraine or the attack tractability or disability. So for example, you may start a preventive treatment, or you consider starting the preventive treatment in those who are having attack less than 4 per month, but still the attack are tractable or disabled. These are the classical oral preventive treatment, which are classified according to the level. We have level A, level B, and level C, and others. And we can see here clearly that under level A, the commonly used preventive treatment, which is Topamax and Enderal, beside the onabotulinum toxin A, which was approved as a level A for chronic migraine. Then under level B, we can see the antidepressant. Then other level C, you can see the antihypertensive beside other agents. With this wide variation of choices of the preventive treatment, we have unmet need in the management of migraine. And this one of the study that have been studying or addressing this issue regarding the management of migraine. And through this study, they took the patient with a chronic migraine and followed them over 1 year, and only 25% will persist on their treatment at 6 months. And at 12 months, only 14% remain on their prophylactic treatment. Those who stopped their medication earlier time, a percentage of them switched or reinitiate. And at the end of 1 year, still a lower percentage continue taking this medication. And this low persistence mostly due to the low tolerability of this medication and maybe modest effect of this medication. Therefore, an attempt was done trying to find a key element in the pathophysiology of migraine or the step of the migraine itself with a good tolerability and higher efficacy. And with this attempt, they revealed they found the target, one of the targets, cyclic GRB, which is a 37 amino acid neuropeptide, which is also abundant in the nervous system, particularly in the trigeminal vascular system. It can be found in other parts of the body, like GI system, yet their clinical relevance is still unestablished. CGRB thought to regulate neurogenic inflammation, pain transmission, as well as vasodilation. The link that was found between the CGRB and migraine is that the level of the CGRB was high during the migraine attack, and then when the symptom resolved, the level normalized. Moreover, those who were given a cyclic GRB and those with susceptible patient, it triggers a migraine-like attacks. Medication that are targeting the CGRB itself or blocking the receptor of the CGRB will also not only, decrease the CGRB level, it's also will lead to the resolution of the symptoms. These are numbers of the anti-CGRB therapies, some of them targeting the CGRB itself, the molecule itself, and other targeting the receptor. The mechanism of these therapy thought to be due to the reduce of vasodilation, reduce neurological inflammation, reduce the afferent signaling, as well as modulation of the pain transmission and modulation of pain perception. We'll start talking about the monoclonal antibodies, which is a large molecule that cannot cross blood-brain barrier. It's fully humanized and work mostly in the peripheral part of the trigeminal vascular system. The advantages of this therapy is that it has a long half-life, no hepatotoxicity, and no drug-to-drug interaction. To the date, we have only 4 FDA-approved monoclonal antibodies. The latest one is the eptinezumab, which was approved in February 2020. All of them have a similar half-life. All of them are targeting the CGRB itself, except the irinumab, which is targeting the receptor. The first 3 are giving as a monthly injection through sub-Q route, and except the firminizumab can be given either as a monthly dose or every 3 months, where eptinezumab, which is only given through IV infusion, is only given also as every 3-month dose. These are the phase 3 trial for both episodic and chronic migraine. And the primary endpoint of all of these trial was a reduction in the monthly migraine days. And all of the study was significantly meeting these primary endpoints, beside most of the secondary endpoint of this study, which are a percentage of patients who receive a 50% reduction, percentage of patients who have a reduction in the acute use of a treatment, as well as improving quality of life. These are the summary of the cyclic GRB in episodic migraine. And this is one of the secondary endpoints, which is a 50% reduction. And we can see here that the monoclonal antibodies achieve this target with a significant difference when compared to the placebo. This is also a 75% target. And also the same thing with the monoclonal antibodies in the chronic migraine. So also all the monoclonal antibodies reach this target with a statistical significance when compared to the placebo. So clearly, we have a good medication with good efficacy. But again, we are still wondering whether these drugs can act fast. Because one of the problem with the classical oral preventive treatments is not the tolerability issue. So also it needs time to work. And usually you tell the patient that you need to wait like 2 to 3 months to start seeing the effect. So this issue also have been addressed in the trials. And we can see in the PROMISE study for the eptinezumab in both episodic migraine and chronic migraine that the separation started as early as day 1, where we can see it in the firminizumab in the chronic migraine, well, where the separation point started at within the first week. And this is also true with erinumab and gilcanizumab. And both of them, the separation point started within the first week. So still, we have a concern regarding some subset of patients or subgroup of patients who are refractory to the oral preventive treatments, who have a coexisting medication overuse headache. So what to do with this patient? So this is a Liberty study which addressed this issue. They studied those who have a previous history of failure of medication, and they gave them erinumab. And the primary endpoint was a 50% reduction. And the drug did not only meet the 50% reduction, it's also made the 75 reduction. It's also work fast. And this also have been true with the galcanezumab in both episodic and chronic migraine through the CONQUER study, where the primary endpoint was reduction in the MMD, and then the secondary endpoint, which also was met by a 50% reduction and 75 reduction. What about those who failed Botox? These are a post hoc analysis of patients who received galcanezumab and those who failed Botox. And clearly, we can see that the separation point started within 1 month. And there was a statistical difference between those who achieve a 50% reduction, those who have a reduction in the MMD, and those who have a reduction in the use of the acute therapy. So those who have the medication overuse headache also been studied and evaluated, especially in those with the chronic migraine. And we can see that there are statistical difference when compared to placebo. And in fact, there was no difference when we use it in both groups, whether they have medication overuse headache or no medication overuse headache. More patients achieve a 50% reduction, and more patients with the treatment with the erinumab achieve a reduction in this in the use of the acute medication. And these also have been shown to be act as early as within 1 month. These are 2 meta-analyses which studied the safety profile. Overall, these medication have a good safety profile and no safety concern with a good tolerability, low discontinuation rate, which was around 2.5%. Commonly reported side effect was injection site reaction, nasopharyngitis, upper respiratory tract infection, constipation beside the other listed here. Anti-drug antibodies was also evaluated, and some of the patients who were receiving this medication developed it during the treatment. However, most of the time it was transient, and even with subsequent injection, it disappeared. These antibodies has no effect in the efficacy of the treatment. Cardiac safety also been evaluated through a randomized double-blind placebo-controlled study. They gave erinumab in those who have a stable cardiovascular disease, and the primary endpoint is a change in the timed exercise treadmill test, which is a marker of cardiac ischemia, and they found that erinumab has no effect in this parameter. Therefore, monoclonal antibody could be a promising option for those with a stable cardiac ischemia. In effort to organize the prescription of these medication, these 2 society publish a guideline or consensus regarding when to start this medication. And both stated that you should consider trying this medication in those who failed at least 2 class A, class B preventive treatment with a proper trial of 6 weeks, or if they don't tolerate this medication for both episodic and chronic migraine. And they added with the chronic migraine that the patient need to fail at least 2 cycles of onabotulinum toxin. These are the patients you don't want to start them in the monoclonal antibodies, and the recommended duration of the treatment was 6 to 12 months. Regarding long-term data, we want to ask whether these drugs are safe in the long-term use. Is the safety maintained? Is the tolerability maintained? So these have been established with this open-label study of Erinumab, a 5-year data, and it's clearly during this 5 year that there was no safety concern, low discontinuation rate, high tolerability, and no concern regarding anti-drug antibodies. Efficacy was not only maintained, but also improved with the time. And we can see that a higher percentage of patients reaching the target of 75% and 100% reduction. So at 5 years, we can say that around 50% of the patients achieve at least a 75 reduction. And even we can see some patients achieving 100% reduction of their attack. This is also have been true with the Firminizumab in both episodic and chronic migraine. And you can see in the graph that the efficacy is not only maintained, also improved with the time. Also with the Galcanezumab and Eptinezumab in chronic migraine. And all of these studies show no safety issue, high tolerability, and low discontinuation rate. So we can give monoclonal antibodies for those with chronic migraine and episodic migraine. We don't care if the patient have a medication overuse headache. They are safe, high tolerability, efficacy can improve with the time, and moreover, it will improve the quality of life. So this will impact your practice is that you don't care anymore to differentiate between episodic migraine and chronic migraine as you do with the Botox. You don't need to care whether the patient have medication overuse headache or not, or you don't care to, or you don't need to bother yourself teaching or explaining to the patient how to withdraw medication overuse headache. Therefore, you can just start monoclonal antibodies and you can see that the medication that have been overused will drop out. Going or moving to the G-band, which are a small molecule antibodies that are targeting the receptor. Usually they are taken through oral route, and original study was done assessing their efficacy in the as abortive treatment, and these are the phase 3 trials assessing the Yobrigimab and the Rimigimab, which was meeting the primary endpoint, which is a pain freedom at 2 hours. They are highly effective. They have a high tolerability with low discontinuation rate. Those who have a cardiovascular disease or cardiovascular risk factor also have been involved in this study, and there was no cardiac concern with this study. What is interesting with these studies also that there was no risk or low risk of medication overuse, and based on this concept, this medication was evaluated as a preventive treatment, and this is a phase 2-3 trial which assesses the use of Rimigimab as a preventive treatment in both episodic and chronic migraine, and we can see that the primary endpoint was met in a reduction of the MMD as well as reaching the 50% reduction, as well as improving the quality of life. There was no safety issue. There was no low discontinuation rate, and there was no concern regarding hepatotoxicity. Atogibant is another agent which are given again through oral route. The half-life of both Gibant is around 10 hours. They assess the patient with episodic migraine with a different doses and different regimen. And again, the primary endpoint, which is a reduction in the MMD, as well as the secondary endpoint, which is a reduction of 50% or more, and even reduction in the acute therapy was all met. Safety profile was there was no issue or no concern regarding safety profile, as well as the hepatotoxicity, and there was a low discontinuation rate, and side effects usually, if it happened, it will be moderate and tolerated. The company announced a positive result of phase 3 trial of the atogibant through the advanced study, and they used 3 doses. And the primary endpoint was the MMD reduction, which was significantly met, as well as one of the secondary endpoints, which is a 50% reduction or more, and also met. And again, no safety concern, no hepatotoxicity, high tolerability. So this medication, the Gibant, are going to be approved soon for the preventive treatment. They are, as I said, effective in both abortive treatment and the preventive treatment. They have short half-life. They have a good tolerability with no safety concern. And they are a good option. You may consider this patient in those who have a cardiovascular disease, who prefer or who have a needle phobia. They can be used in those who have an unplanned pregnancy or a planned pregnancy. Thank you so much.
Thank you very much, Dr. Khalifa. This is an outstanding presentation with lots of data. I do really appreciate your time collecting the latest evidence on updating the management of migraine and shedding the light, especially on GPANs for the abortive and prevention of migraine. Really, thank you so much. Our next speaker is Dr. Bader Al-Mas'ad. Dr. Bader is a graduate from Ireland, from Medical School Ireland, and he did actually, he's in neurology. Dr. Bader is one of the excellent actually neurologist specialist in Kuwait, one of the excellent clinical tutor actually in the Kuwaiti neurology program. Dr. Bader is he's the first batch actually of Kuwaiti neurology program graduation. We're really proud of him actually, Dr. Bader. And Dr. Bader today will speak about treatment of idiopathic diagnosis and management of idiopathic intracranial hypertension. Dr. Bader, the floor is yours.
So good morning, everyone. I would like to thank Dr. Jassim and the organizers for inviting me to speak here. So we'll talk about intracranial hypertension, or as it was known previously as pseudotumor cerebri. It was also known as benign intracranial hypertension, and most lately as idiopathic intracranial hypertension. So as you can see, there was many terms used to describe this disorder, and it may suggest that there was some confusion regarding the cause of this disorder, and there still is some confusion. It is a disease of middle-aged obese females usually. So that is the typical patient, and that is when we term it as idiopathic intracranial hypertension. So the annual age-adjusted incidence in 15 to 44-year-old females was found to be 3.3 per 100,000. Now, if you do the same with obesity, so that would be patients who are 20% above the ideal body weight, it was found to increase the incidence to around 19 per 100,000. So as you can see, obesity is highly related to this disorder. Now, these patients usually present with headache, Okay, so it is more common in obese patients. Sorry for the delay. More common in obese patients, as we said, in obese females, and typically they present with headache, pulsatile tinnitus, and transient visual obscurations. And as you can see, headache. Some patients may present without headache, so it's not all patients that have headache. In this slide, you may see this graph. You can see the incidence and over the last couple of years. So as you can see, 2002, the incidence per 100,000 was around 2, and this has increased, more than doubled over the last 15 years or so. And in the lower graph, as you can see, in the purple is the female patients, blue is male patients, and with increasing incidence of obesity, there is increasing incidence of IIH. However, that was not the same with male patients, and this may suggest other causative factors such as hormonal profile. Another thing is as you can see here, it's more common, as we said, in the middle-aged. Pointers. Okay. So what is the cause of IIH? It is still not completely understood. We know that it's more common in obese patients, and this may be related to obesity being a chronic inflammatory disorder with the release of cytokines, adipokines, leptin, which has been found to be increased in the CSF of IIH patients, and other enzymes. In addition, obesity may lead to venous stasis and increased venous pressure intracranially. We'll talk about that later. So it's either increased CSF production or decreased CSF drainage, which lead to high ICP. A postulated mechanism for decreased CSF drainage would be that there is, as you can see here, this suprasagittal vein may have elevated pressure due to distal obstruction, even down in the neck, or due to obesity. There is there's increased pressure due to the compression on the pleura and the cardiac vessels, and this may go up into the suprasagittal sinus because there's no valves in the draining veins, and this may lead to high pressure. This will lead to decreased absorption of the CSF to the arachnoid villi. So obesity can lead to IH through many different mechanisms. As we said, increase in abdominal pressure may lead to reduced CSF absorption through the arachnoid villi. Obesity can produce a hypercoagulable state, which may lead to occult cerebral venous microthrombosis, and this may lead to reduced CSF absorption. And then there's many hormones that are secreted from adipose tissue, including the mineralocorticoids, which may ultimately lead to increased CSF secretion. So what are the symptoms of IIH? We all know that it can cause headache. The headache characteristic varies, but it usually is insidious in onset, and it is progressive and continues to become more severe, present in the majority of patients. Visual obscurations are described as sudden darkening of vision or blurring of vision by the patient. They are exacerbated by movement, for example, praying or sujood or walking. And it's quite specific for high ICP. Pulsatile tinnitus would be a pulsating, whooshing sound like a heartbeat in the ears. And then there's other symptoms, such as back pain, which may be radicular. Interestingly, they may have cognitive disturbance. In a 20% of patients, they will have cognitive disturbance, and this usually does not improve the treatment of the IIH. It may persist. What are the diagnostic criteria? So they are the modified Gandhi criteria. You need to have A to E. So headache with papilledema, normal neurological exam, except for a sixth cranial nerve palsy, which is a sign of high ICP. You need to have the normal neuroimaging, so normal brain parenchyma, and you need to rule out venous thrombosis. you need to have normal CSF, and you need to have a high opening pressure, which we'll touch about later. This is just to show you, remind you of the grades of papilledema: 1, 2, 3, 4, and 5, with obscuration of the vessels, and starting in 3. And just as a note, always make sure that you don't have a case of pseudopapilledema, which we commonly see. So always make sure that patient is, if you're not sure, to be examined by an ophthalmologist or a neuro-ophthalmologist. You can do an OCT and other tests. So there is an entity called IIH without papilledema. Okay, this has been added to the diagnostic criteria. This is from the consensus guidelines in 2018. And you need to have criteria B to E with either a unilateral or bilateral 6-nerve palsy or neuroimaging findings suggestive of IIH. So at least 3 neuroimaging findings. And this at the bottom shows you the opening pressure. 25 to 30 is somewhat of a gray zone. If the patient is obese, usually we take a reading of above 30 to be significant. So why does IIH happen without a papilledema? Why can't, I mean, it's not clearly understood, but the proposed mechanism is that there is compartmentalization of the subarachnoid space here around the optic nerve sheath. You may get ramifications and obstructions, and this may lead to impairment of transmission of the pressure down to the optic disc, and so you don't see any optic disc edema. As you can see here in an example, there is asymmetric edema more on the left. You can see here in the T2 imaging that there is dilatation of the optic nerve sheath bilaterally, and this is a CT cysternography, and you can see contrast failing to transmit forward towards the optic disc. So there's something obstructing here. This may be asymmetric, one-sided, or bilateral. So these are the common neuroimaging features of IIH. As you can see in the first image, there is an empty cella sign. You can see here dilated optic nerve sheath. You can get tortuosity of the optic nerve. You can get stenosis, which commonly is seen with the in the transverse pathway. It's stenosis and not thrombosis. And you can get flattening of the posterior globe. So how would you diagnose such patients? You need to do a good ophthalmological exam, investigations. You check the visual acuity, color vision, formal visual field testing, and check extraocular motility, and do, of course, a fundoscopic examination to check for papilledema and the graded papilledema. Should you do MRI, MRV, CT, or CTV? In most patients, usually we do MRI, MRV. And this is because MRV is more useful in detecting the other possible causes or differentials, such as fistulas and any meningeal disease and the subtle signs of IIH. But in typical patients with IIH, a typical patient, so middle age, obese, CTV may, if that's what's available, it can be enough. Lumbar puncture should be done in the lateral position. Patient should be relaxed, extend the legs before measuring. Common associations that have been reported to cause raised ICP. So when you take a history, the most important thing is to check if the patient has a recent history of weight gain. This is a risk factor. If there is any hormonal imbalances. And of course, check for medications. So the common medications are fluoroquinolones, tetracyclines, which are given usually for acne or skin disorders, and the vitamin A derivatives. So you need to ask about that. If that is present, then of course we need to stop it. This is a typical visual field that you may see in a patient with IIH with an enlarged blind spot and the nasal step. Okay. This is another patient showing enlargement of the blind spot with peripheral constriction, and after treatment, visual field usually always improves after treatment. The normal visual field progression. Okay, so the steps would be enlargement of the blind spot. That is the earliest, most sensitive sign. And then you may get a nasal step, and this will progress to a visual field constriction with tunnel vision. So we'll go straight to management, where there are some issues and changes. So first thing in management, we need to have a general approach. So identify if there's any reversible causes and treat them, such as medications. And then check, the most important thing is lifestyle modifications such as weight loss, low sodium diet, and then you have medical therapy and surgical. So we'll touch on each of them. This is just a way to categorize, or a table to follow. If you have a suspected case of IAH, you would usually start with weight management. And this is advised for all patients with a BMI above 30. You then assess, is the vision threatened or not? If the vision is threatened or the patient has fulminant IAH, you would go towards more surgical approach. So you would insert a lumbar drain and then either go to CSF diversion or optic nerve sheath fenestration. If there is no immediate threat to vision, consider medical therapy with acetazolamide and evaluate the headache. As we know, acetazolamide may improve the headache, but in many patients does not improve. So the headache may have phenotype of migraine or tension, and you need to treat it accordingly. And you need to identify if the patient has medication overuse headache, which can be common in such patients. And then the only disease modifying therapy at present is weight loss. Okay, and it has been noticed that 6% weight loss is usually enough to improve the headache, and 10 to 50% may be able to reduce remission. It should be offered to all patients. You should do a structured weight loss program, not just advise the patient to lose weight. You should give, for example, give them a follow-up with a dietitian or a weight specialist. This will ensure better weight loss. There is no recommendation at present regarding bariatric surgery. However, it is advisable to consider it if the patient is morbidly obese or unable to lose weight. And there is currently a trial ongoing called the IIH weight trial, assessing bariatric surgery versus diet. And they're following up visual fields and disc edema, etc. This is a meta-analysis or systemic review of meta-analysis looking at surgical versus non-surgical weight loss. And it is showing, as you can see, headache improves in more than 90% of patients if they're going surgical therapy, and in non-surgical therapy or diet, the headache improvement is around 20 to 30%, so it's much less. But keeping in mind that patients who underwent surgery lost more weight. Also, papilledema improved in around 100% of patients who underwent surgery. So, but this is a small sample size, and still there is no recommendation regarding for bariatric surgery or weight loss. The important thing is to lose weight, and if the patient is failing to lose weight, to consider offering bariatric surgery. So we'll talk about the medical therapy. The gold standard is acetazolamide or Diamox, which is a carbonic anhydrase inhibitor. And it inhibits the carbonic anhydrase enzyme, which is responsible for ion transport in the choroid plexus, and this will reduce CSF secretion and to reduce ICP. You can see it below in the diagram. Acetazolamide and also topiramate has a carbonic anhydrase activity. So is it recommended? What's the evidence for acetazolamide? So the current Cochrane review reported the following, that there are two RCTs which show modest benefit for acetazolamide for some outcomes. However, there is insufficient evidence to recommend or reject the efficacy of this intervention because there is still not enough high-class evidence for acetazolamide. An initial study done by Ball et al. Failed to show any significant treatment effect, and there was a high discontinuation rate. But the IIH treatment trial, which we'll talk about now, did show improvements. This was done in 2014. It's a multi-center, double-blind, randomized, placebo-controlled trial where patients were randomized to acetazolamide or placebo plus weight loss. So both did the weight loss program. And the primary outcome was perimetry, so visual field function, and then other secondary outcomes were disc edema, quality of life, headache, CSF pressure. Many patients did not agree to a second LP, but some did. This shows you on the first graph on the left In the red, it is acetazolamide plus diet, and placebo is in black. So as you can see, this is a change in visual field function. There is a significant improvement in visual field function starting within the first month. So treatment has an effect immediately, usually. And this persisted. This was significant. And then the same thing with the optic disc edema. It's improved with acetazolamide plus diet, and again with the anti-pressure. Just focus here on the right, the HIT score, which is a headache intensity score, and the visual acuity in this trial, in the IH trial, there was no significant improvement in headache or visual acuity. So the maximum dose they used was 4 grams daily of acetazolamide, which is a big dose, and the majority did tolerate 1 gram per day. What we usually do is we start 250 milligrams twice a day or 500 twice a day, depending on the patient, and then you titrate up, usually to a maintenance of 1 gram, and you follow up the patient, and you can go up. The patient is tolerating. The main side effects would include paresthesias in the oral, in the face and the peripheries, and altered taste sensation. They can get nausea, fatigue, and you should advise them to watch their fluids because they are at risk of renal stones. So what was learned from this study? This was the first proper RCT for acetazolamide, and it proved that it works. And the effects were independent of weight loss. It was controlled for weight loss. So disc edema is improved, visual field improved, headache not so much. And the symptoms improved within the first month. And in this study, they did not supplement with potassium. There was no need for it. Other medications to consider are topiramate, which we know is used for migraine prophylaxis, and it has a carbonic anhydrase activity and can suppress appetite, which can help you with the weight loss. It has been compared to acetazolamide in an uncontrolled open-label study that showed they were equal. Furosemide, which is a loop diuretic, sometimes it's mainly used as an add-on therapy in low doses. So what are the surgical options? We know we have optic nerve sheath fenestration and CSF diversion, and cerebral venous sinus stenting. And these are usually reserved for moderate to severe visual loss or when medical therapy. There is no prospective randomized studies not to compare them, although there is one currently ongoing comparing VP shunt to optic nerve sheath fenestration. What is optic nerve sheath fenestration? The ophthalmologist would do it, and they would make incisions in the optic nerve sheath to allow pressure to dissipate through and the CSF to go out. This improves the visual field. It's mainly done to save the vision in the eye, and this can have an effect in the contralateral eye, even if it's done on one eye. 1/3 to 1/2 have no improvement in headache. So this is not done. All surgeries are not usually done to improve headache. They're mainly done for vision. It has some complications such as hemorrhage, diplopia, and a higher vision rate. The preferred CSF shunt would be ventriculoperitoneal shunts rather than lumboperitoneal because of a lower chance of revision. It is effective in improving visual acuity, visual field, and papilledema. Not so much headache. Complications of shunts, as you know, can be abdominal pain. You can get shunt obstruction, migration, low pressure headaches, which can be common. What about venous sinus stenting? So still not 100% clear if this is causing the IAH or because of the high ICP you get stenosis. However, there is a review that showed that with significant improvements in headache, visual symptoms, however, the sample size was small. So there still is no recommendation for venous sinus stenting. If you consider it, it's considered in medically refractory patients with clear sign of venous sinus stenosis on MRV. You need to do a conventional angio and make sure there is a high pressure gradient across the stenosis, and the higher the gradient, the more they will improve. Usually done unilaterally, not bilaterally, and you need to be on antiplatelets after it. And then how should IH? We'll go through a few questions, common questions that we encounter clinically. So how should IH be treated when there is an imminent risk of vision loss? So patient is progressively becoming worse, vision is dimming, and or there is severe presentation with severe constriction and so on. So the treatment would be surgical. Okay, so you should consider inserting a temporary lumbar drain and then either optic nerve sheath fenestration or a VP shunt. And previously it was mentioned that you can use corticosteroids, still use sometimes, but there is no recommendation to use corticosteroids for permanent IH at this time. You should insert a drain as soon as possible and then choose either surgery. What is the best way to manage headaches in IH? As we said, it does not usually improve with the traditional therapies. So, and headaches can commonly have a migraine character or a tension type character. They are commonly have medication overuse headache because of the common abortives. So if you have an acute headache, you want to abort the headache, you can use NSAIDs. And then later on follow-up, if you want to reduce the headache, you can use the typical migraine preventative therapies. If the phenotype is migrainous, you should be careful when using therapies that increase weight gain or increase depression, because these are common comorbidities, so such as Inderal or Ceptazole. Topiramate would be a common go-to because of the carbonic anhydrase activity and weight loss. Should CSF diversion procedures be done to manage patients with IH with headache alone? So only with headache. In that situation, that it should not be done, because as we said, they are not very good for reducing headache. So a patient with a shunt comes to you with headache, how should you approach? Is there signs of infection? Or if there is papilledema and vision deteriorating, you should liaise with the neurosurgery and revise the shunt. If there is no papilledema, or there is papilledema but the visual function is stable, you should do an LP and investigate for other signs of headache. What about pregnancy? In short, it usually doesn't become worse with pregnancy unless there's a great weight gain. The use of acetazolamide is controversial. There has been some reports that it may increase the abortion rate. Topiramate also shouldn't be used. If there is a potential for a prolonged second stage of labor, you should consider assisted delivery. What about new therapies that are being studied? So GLP-1 agonists, which are used in diabetes, already established and available, have been shown mainly in vitro to greatly reduce ICP. And there's a pathogenic basis for this because it's present in the coral plexus and decreases CSF secretion. This is the last slide. There is another enzyme called 11-beta-hydroxysteroid dehydrogenase type 1 in the coral plexus. This converts cortisone to cortisol and is responsible for CSF secretion. There's already a trial that has nearly finished, which studied this molecule in a phase 2 randomized control fashion, and the results are still awaited. So this is a possible also new treatment coming. And I thank you for the time.
Oh, thank you very much, Dr. Badr. This is an excellent presentation and update on the management of idiopathic intracranial hypertension. While we make the setup for the next session, which is the stroke session, so we have some questions for the speakers here. For Dr. Badr, now, people on pregnancy and they are on Diamox, what is the best management? Will you continue the treatment for the Diamox on these patients, or how you can titrate the medications for these patients on Diamox and while they are pregnant?
So the manufacturer recommendation is to avoid Diamox, or there is a warning about Diamox use in pregnancy. If a patient is with resistant IIH on needing the Diamox, you may consider continuing it because it's still not very clear, especially if they're already in the second trimester. And you should explain this with your patient. Another option to use would be Lasix, which can be used at times in pregnancy. And ideally, if the patient is planning pregnancy, you should try to discontinue the Dimox beforehand and make sure they are at a good weight, and avoid the weight gain during pregnancy, because this weight gain inappropriate to the gestational age. Yeah, what I came across was that it is part of the pathway of secretion of CSF in the coral plexus. It is present in the coral plexus itself, the receptors, and they found that giving GLP agonist or antagonist can decrease the CSF production and decrease ICP greatly.
Any of these other GFANs will be used in prevention of migraine. Or any of the GFANs, the small molecules, so for prevention, not for acute therapy of migraine.
Yeah, for the prevention till now, they are going to be approved. We are waiting for the approval. We have announcement for the atogibant phase 3, but still we are waiting for the approval. These are the two that I'm aware of the G-band that have been studied for the prevention as a preventive treatment for the migraine.
These are the main questions received for the physics sessions. So just to briefly tell you that we spoke about the test presentation was trigeminal autonomic cephalalgia and the types of trigeminal autonomic. The outcomes and cost of biologics. So I think they are linked to the monoclonal migraine and migraine and clinical practice. I can take this question. So here there are two sectors or healthcare system in Kuwait has private sector and the governmental sector. So the biologics or the monoclonal came first to the private sector after the approval of the Ministry of Health, then they came to the governmental sector. So the cost of each injection, we have the availability here of Emgality or galcanezumab, and also the other one is erinumab or called Aimovig. So they are exactly the same price each injection. The 120 injection Emgality costs 205 kd. So that's around, it comes to around $600 US, for example, more or less, and the same price for Emgality. So the Ministry of Health made sure that there will be no change in the price between the two types of medication. It's a bit costly, but when you look for the long-term outcomes for these patients, they do very well. If you calculate the whole economic burden of these patients actually over the whole time with the admission to the hospital and the complications will probably become the same. Well, our last question, Sue, do GFANs now approved for abortive treatment or not yet? So
Yeah.
Dr. Khalifa?
G-band is approved for abortive treatment. Both rimegibant and yobrigibant was approved for preventive treatment. There are phase 3 trials and they are approved to be used as a abortive treatment.
Yeah, so rimegibant and yobrigibant. So yobrigibant is actually by AbbVie. This molecule is initially actually Allergan, but now Allergan company is bought by AbbVie. Now the whole Allergan became part of AbbVie company, and also Biohaven is the other company for the rimegibant actually. So those two molecules, they have an FDA approval now as a preventive therapy, and they are probably working. And as Dr. Khalifa said, the idea why these molecules came to people, they think that they can be used for prevention because there was no medication overuse. about no medication overuse headache from these medications, and that stimulated that. Can we use these medications as a preventive therapy for patients with chronic migraine or high frequency insomnia? So I'll leave the floor now for our next moderator, Dr. Abu Bakr Kalam, who is a consultant neurologist and epileptologist. He will moderate the next session.
Dr. Adani. Okay. So I don't know if you were hearing me earlier. I would like to introduce Dr. Adari Salmin. She's one of our prominent neurologists in Kuwait. She works in Jaber Hospital. She has completed her neurology training and stroke fellowship at the University of British Columbia in Vancouver. She will give us an update in the management of ischemic stroke. So just a few technical issues will be solved in a minute. Okay.
Okay. Good morning, everyone. So I was asked to talk about updates in ischemic stroke, and I'm going to be biased and say that probably stroke is one of the most growing field in neurology overall. So what's there really to consider as an update? Personally, for me, I want something that would either change my practice in the future, it would answer some of the questions or emphasize some of the things that we are doing right now without a level A evidence, or bring out more questions and more debates asking for more RCTs in the future so that we get a better answer. I have no disclosures. So I divided my talk predominantly into the reperfusion therapy, where I will be talking about EVT with thrombolysis or without thrombolysis. I'll briefly discuss also the extending time window for IV thrombolysis, speaking about TNK, and then at the end, I'll just talk about FILS and TST as stroke prevention updates. So we know that IV TPA doesn't really work for those with the long segment. It has limited time window, and that's when EVT came on as a big hit for us. Now, the question is whether we need to combine it or not. So what happened is when we tried to do the combination, the idea is we may be able to facilitate those endovascular reperfusion. We may be able to dissolve those distal clots that I'm not going to be able to reach with a thrombectomy. However, at the same time, we know that combining IV TPA with EVT, the idea is it will increase the risk of having cerebral hemorrhage or other extracerebral bleeds. It will limit my use for antithrombotic afterwards, especially if there's any plan to do any stenting or intervention in the acute phase period. It can delay the start of EVT because not all transfer ambulances are actually ICU equipped ones, so they don't necessarily will have the pump. And there have been some facilities where they will actually have to wait until TPA is completed before they're able to ship the patients for places with endovascular therapy available. And at the same time, we think they may have some limited effect on those large clots. So it will just dissolve those clots or break them down, and then it will have some distal occlusion, further complicating the distal perfusion. The first study I'm going to talk about is direct MT, which is one of the most recent RCT that has discussed combining IV, TPA, and thrombectomy versus thrombectomy alone. It happened in China. The main inclusion had been for older than 18 years old. The occlusions have been including intracranial ICA, M1, M2 segments, or both. They would do it within 4.5 hours of IV TPA, so that we are still within the window. And they only wanted an IHSS of 2 or more, and they didn't really take into consideration the aspect. Overall, 656 patients have been enrolled in this trial, and the population have been similar between those with EVT group versus combined group. The median age was approximately 69 years old, 56.4% were men. The median NIHSS score was 17, so even though they wanted to include all those above NIH of 2, they did eventually get quite a severe stroke with a very good aspect of 9. Interestingly, if you look at the time between randomization to groin puncture, for the EVT alone, it was only 31 minutes, whereas the combined was 36 minutes. So it really just caused a 5 minutes of delay from starting the EVT. Of those 656 patients, so 591 underwent thrombectomy or EVT, where there was an actual contact between the, like after the groin puncture with the clot itself with some sort of devices. And in the combination group where they received both, note that about 86.5% completed during EVT. So it wasn't like we needed to wait to see if the IV-TPA had worked before we actually go ahead with EVT. And this one did actually confirm the non-inferiority of thrombectomy alone to combination of thrombectomy and IV-TPA with the confidence interval of 0.81. So it just barely passed the confidence interval of 0.8 that was required for the non-inferiority. And this is why they did not go ahead with looking into the superiority. Otherwise, looking into the secondary outcomes, the only one that was actually significant was for where they tried to look into the successful reperfusion before thrombectomy, and it was found to be higher in those with a combined treatment. For the safety outcome, it really did not affect it any significantly, but you can see a higher trend toward those with a combined. And from this one, we can conclude this Chinese one that overall there was non-inferiority confirmed, and it did not really have any significant effect on the symptomatic ICH or the mortality. The second one is a skip that was predominantly in Japan. So remember that Japan guidelines actually state for IV-TPA dosage to be 0.6 mg per kg. The other inclusion have been for ICA occlusion or M1. They did not include the M2, NIHSS of 6 and more, aspect also of 6 and more. And they only included 204 patients, of which were divided between mechanical thrombectomy and the combined. Similarly, the median NIHSS was of 18, so it was still quite a severe stroke with a good aspect. The predominant vessel occlusion had been for the M1. And from this one, 199 patients went for the actual mechanical thrombectomy again. And when we compare the randomization to puncture time, it was not statistically significant between the two groups. Even the rate of clot migration, which was one of the concerns that we talked about earlier, was not significantly different between the two groups. So in this one, neither the primary analysis nor the per protocol analysis confirmed any non-inferiority. So this was not proven here. If we try to look into the secondary outcome, again, there is like some trend toward, there is some trend toward similar to what we just said in the previous study with the tachyperfusion being better for those with a combined, but none of it actually was significant. For the adverse outcome, the significant results had been for any ICH within 36 hours. So that was already a planned CT at 36 hours. That looked into it and found to have more bleed. However, if you look into the symptomatic bleeds by NINSU criteria or most, none of them have had significant difference between the two. The last trial regarding the combined EVT and IV-TPA is the DEVT ones, which was again another multi-center randomized controlled trial in China. The included vessels have been for intracranial ICA or M1 occlusion, and patients would be eligible for IV-TPA within 4.5 hours, similar to what we have just said. And the number that was included in this trial had been 234 patients. Of this one, similarly, like the NIHSS had been about 16 for both groups, so we're still taking the severe stroke. This trial was terminated early because they did reach the threshold for non-inferiority. So according to the steering committee and the safety, they thought it was reasonable to stop it just because the evidence was so out there. So the non-inferiority was actually demonstrated for EVT alone compared with the combined with a p-value of 0.003. If we look into the disability, so it has a 0 for unadjusted difference with the confidence interval of -1 to 0. The bleeding risk overall using the HBC criteria actually did not show much. It just showed it to be similar to the skip one that we just talked about, in spite of the skip one using a 0.6 mg per kg for TPA dosages. Mortality, again, no significant difference. So we have so far some studies that did prove non-inferiority, other studies that did not prove non-inferiority. We still have some ongoing study, including DirectSafe and SWIFT Direct as well. Mr. Clean No IV trial results have been preliminary published in ISC conference this year only, and again, it did not show non-inferiority nor superiority for the combined, for the EVT alone over the combined. So overall, what we will do at the time being is still we'll offer the IV TPA prior to proceeding with EVT. Now, briefly, we'll talk about the extending thrombolysis time window. So we already, by now, know there has been quite a few publications that had shown the efficacy of TPA for those who present more than 4.5 hour window from the onset, the wake-up strokes, and the unknown onset, depending on the type of imaging that we do, whether we did the MRI with DWI versus a FLAIR comparison, or we were depending on the perfusion images, whether CTP or MRP. And this has shifted our definition from time-based to tissue-based for a stroke window. I'm just going to talk about this meta-analysis by Dr. Campbell and his group, where they looked into the 4.5 to 9 hours time window, including 3 studies, Extend. So that was the one that looked into between 4.5 hours to 9 hours. This study was terminated early. And similar thing with the ECAS-4 also was terminated early, and Epithet, which looked into 4.5 to 6 hours. So combined population that they got was about 414 patients. Half of them have been wake-up strokes. And about 403 of those have had some vessel imaging done, and we would have estimated about 61% of those would have been candidate for thrombectomy, but because all those trials were done before thrombectomy was part of the guidelines, so it was not really included in those. Now, if we try to look into the median perfusion of mismatch, it was 47 ml. The median volume of critical hypoperfusion on the perfusion scan was 64 ml, and the relatively small core median volume was 8. And overall, this was quite a positive for the primary outcome as well as secondary outcome. So this just emphasized that we can still give TPA if we extend the time window, have we had the right imaging. Then they tried to use those patients specifically who have had automated rapid software, because this is the most common one that has been used. And so they included 304 patients with those. And again, this was further emphasized, and they noted that those who have had perfusion imaging actually through the rapid actually have had better compared to those who have not had it. And sorry, just because before I continue further on, please note that I know that earlier on MRI had a big role for it, but just remember that sometimes when we use MRI alone without actually depending on our perfusion, we may still miss some patients that have EHCP perfusion for would have been candidate for the delayed time window, whereas in MRI they would still have shown the high flare signal. The last one for the acute reperfusion therapies will be TNK, which is quite a hot topic, and I'm very optimistic for future use of TNK. So this is a genetically modified TPA with 3 different point of mutation. It has higher affinity for fibrin, it has longer half-life than TPA. It already has been established for coronary syndromes, where it would have equal efficacy to TPA and lower major bleeds. The beauty about TNK is that you give it as a bolus over 5 seconds. And you don't need to have that pump, at least for the ship and drip issues that we have discussed earlier. Again, multiple trials did come out that showed efficacy, that tried to show efficacy or at least non-inferiority. One of them have been NORTHEST. So NORTHEST used somewhat of a minor or mild strokes, but this did prove the safety of TNK rather than the non-inferiority for it. The Extend IA TNK use it predominantly prior to thrombectomy. I'm just going to focus on this meta-analysis that has included the big trials for TNK overall. So you'll notice that the overall have had different inclusion criteria with different median NIHSS for them. There is even a different dosages for the TNK among them, but the median NIHSS overall combined those studies have been about 7. So we're still not quite a severe stroke. And it did show a high probability, it did show non-inferiority of TNK compared to TPA within the different dosages that were included. Similar thing when they tried to look for the secondary outcome with the functional independence, there was still a trend presented there with confirming a non-inferiority of 2 of the endpoints compared to the third one. So they had like 3 margins for the non-inferiority and it only confirmed 2. If you look into the bleeds overall, it didn't really show much. And then there is this most recent that was published last year where they tried to compare the different dosages of T and K 0.4 versus 0.25, because those were some of the dosages that were used earlier on, and they didn't find any extra benefit if we have increased the dose to 0.4. And this is why the guidelines currently emphasize on T and K of 0.25. So in 2019, that was the most recent AHA, it did say it is reasonable to choose T and K over IV-TPA if there is no contraindication for thrombolysis for those who will go for mechanical thrombectomy. ESO were published only this year, and they actually acknowledged or suggested that T and K would be used over TPA for those prior going to thrombectomy. We still have, again, some ongoing trials to see if we can use T and K instead of TPA as a first line for thrombolytic and stroke patients, regardless of thrombectomy. Regarding the prevention, I'll just briefly talk about THALES. So THALES actually have been quite a good RCT, most recent published, again, comparing a dual antiplatelet with ticagrelor and aspirin versus aspirin for those patients with non-cardioembolic minor stroke with NIHSS score of 5 or less, or high-risk TIA defined by ABCD2 score 6 or more, or if they have had an associated ipsilateral atherosclerotic stenosis of 50% or more. The randomization time period had been within 24 hours. They would only need to have brain imaging that have excluded ICH overall. And in this one, about 11,000 patients have been included in the trial. And during this trial, they did still try to control for other significant risk factors, like the hypertension, statin use, glucose control as well. And otherwise, the population between the two have been quite similar from baseline characteristics. And they did find if you use the combined ticagrelor and aspirin, it would actually improve the stroke or death as a primary outcome. And this is likely driven by the improvement in the stroke rate within the first time period monitored. And furthermore, from this THALES, they tried to do a sub-analysis where they wanted to see that benefit for those patients specifically with atherosclerotic diseases. So that was defined as patients with symptomatic intracranial or extracranial arterial stenosis, those with 30% or more for narrowing in the diameter of the artery that have accounted for the presentation, irrespective of the aortic arch plaque. Of that, approximately 20% of THALES population had been included in this trial, and they did find, again, positive results that the primary outcome had been reduced in those patients who have had dual and ticagrelor and aspirin compared with aspirin alone, with the number needed to treat of 34. And even if you want to compare it with those with intracranial athero versus those without, those with atherosclerotic compared to those without, they still found the benefit is higher in those with atherosclerotic patients. Again, similarly, the primary outcome have been significant for those driven predominantly by the ischemic stroke. And again, interestingly, the disabling stroke also have been improved when you do the dual antiplatelets with ticagrelor for those patients. And then they tried to compare specifically intracranial versus extracranial, and they found that the benefit is more so with the intracranial, more significant at least. So this is now becoming an option for us to consider in such situation. In the subgroup analysis, they found that Asians tend to benefit the most and those who have weighted less than 70 kilo. Now, another subgroup analysis that tried to look into preventing disabling the stroke, as I mentioned earlier, because this was found to be positive in those with atherosclerotic patients. And we know from Point and Chas that aspirin and Plavix would reduce your chance of having stroke, of having MI, of having cardiovascular death, but it didn't really look into reducing disability overall. So taking into the same population, they found that there was improvement in those patients with MRS more than 1 at 30 days, with the number needed to treat of 133 patients. Similar thing for ischemic stroke related disability for their secondary outcome. Also, it was significantly present with a number needed to treat of 112. And we have an ongoing trial, which will be quite interesting chance too, where they will be comparing ticagrelor and aspirin versus Plavix and aspirin, because as you all probably know, there has been some debates about Plavix because of this genetic susceptibility that not all patients will be able to respond to Plavix as good. Last but not least is stroke to target. So this one was another RCT that focused predominantly on treating the level of the LDL rather than giving the optimal dose of atorvastatin in those patients. This was predominantly meant to be in France, but because of the slow recruitment, eventually they added South Korea to it. Again, they wanted patients with an indication for LDL control. So those will be patients with atherosclerotic disease, with their intracranial or extracranial cerebral, or they have had even IPSI or contralateral related to their presentation, if they have had aortic arch plaque, if they have history of coronary artery disease, and if there's any recommendation in the guidelines that will emphasize this patient need to be on statin or on controlled LDL level. And the groups that they had was for LDL less than 70, so that's LDL less than 1.8, and the other group for the higher target is 90 to 110, so that's 2.3 to 2.8. Similar thing, they also try to control for other risk factors like hemoglobin A1C and blood pressure and encouraging smoking cessation. So this had approximately 2,860 patients, and majority have had only statin use, but in about a third for those with the lower target, 5.8, and those with the higher target did have the addition of ezetimibe now added on as well. Just if you look, the interesting part at the baseline characteristics between the two, you note that where the second star is, the LDL cholesterol at baseline was actually quite similar between the two groups. Again, as I mentioned, this trial was stopped early because of the lack of funding and the slow enrollment, even after adding Korea later. And at median follow-up, so this is actually quite interesting. So overall, for those with the lower target, they found that the mean LDL was 65 in the lower target and 96 in the higher target. So both kind of had the a low or a good control overall of 1.7 versus 2.5 is really what we've been trying to compare at the time being. And the time spent in that target that they wanted, about 50% in the lower target and 30% in the higher target group. Now, another interesting point is for those who have been meant to be in the lower target, almost a half of them were actually above the target, and the higher target 2 group, almost a half of them have been below the target. If you look into the major cardiovascular event as a primary outcome, it was more prevented or less, at least in the lower target group. And just note that it did not really have any significance of increasing the intracranial hemorrhage that has been always a concern with lowering LDL or being on statin. This another paper that was published that tried to look into the long-term effect of actually having those patients being kept on those targets. And it was mainly on the France population because that was the one that had started earlier on. And similar thing, you note that with those patients less than 70 and in those with 100 received overall statin and ezetimibe in different percentages. And they noted that those patients who were meant to be in the lower target, again, about 47% have had a target higher than 70, and those assigned to a higher target have had 34% actually at the lower than the target emphasized for that group. But again, same thing, the major cardiovascular events were less in those with the lower target. And interestingly also, you note that the cerebral infarction, urgent carotid, cerebral artery revascularization from the secondary outcome also was less in those with the lower target. And the overall emphasis here was that if you spend more time in that target, so it wasn't just about starting a higher dose overall, as I mentioned earlier, you will have more benefit from that lower target. Again, just here to emphasize one more time that intracranial hemorrhage has not been significantly different. The primary outcome on intracranial, when they tried to look at it combined, it was significant, but again, this is probably led more by the primary outcome rather than by the intracranial hemorrhage. And just a quick reminder that we have different guidelines, and I know we don't have anything specific to Kuwait at least or to our region. So it can be quite challenging to know which guideline to stick with, how to follow those updates and what. So you notice that ESO and Stroke Foundation, which is the Australian one, tend to be the most updated overall. They just do it quite quicker compared with North American ones. But I am interested to see what AHA has to say about all those updates that we have talked about. So in summary, the question of EVT, whether we still need to give IV thrombolysis to or not, it's a yes. We still do give IV thrombolysis because we don't have any strong evidence that confirm non-inferiority, but we do have some ongoing trials to look further into it. The extended time window for thrombolysis, again, we just need to remember that this is still possible with the help of radiology and appropriate imaging, and that will be CT perfusion or MR perfusion. The tenecteplase, it is an option prior to thrombectomy, especially for the drip and ship, the dose is 0.25 meg per kg with a maximum of 25. For the ticagrelor and aspirin versus aspirin, so this is a good option for dual antiplatelet for those with minor strokes with NIHSS less than 5 or with a high risk TIA. The benefit seems to be quite better for the, or quite significant for those with like atherosclerotic. So this can be a consideration when you want to question when would you use the Plavix aspirin versus the ticagrelor aspirin. And right now, I think it is reasonable to target LDL rather than just to start on a high dose statin, and don't be scared to add on ezetimibe if the primary target of LDL has not been reached. Last but not least, I just want to congratulate Kuwait for having started on a thrombectomy. This is our first case shared between Jabir Hospital and between our intervention team at Ibn Sina Hospital for a young COVID patient with NIHSS of 18 that after the help of Dr. Lazar, Dr. Peter, and of course the leadership and all of this, Dr. Lamia, who were able to actually drop down his NIHSS to 2 with MRS of 0, and he's functioning excellent right now. So hopefully this is a bright future for Kuwait overall, and looking for more cases of those to come. Thank you very much.
While we are waiting for in fact, there is one question. What do you think about using a multi-dose aspirin, 300 milligrams, in people who are not candidates for IVT?
If patient has not been on aspirin prior to the stroke, you should always load them with aspirin prior to actually giving them the 81 milligram. If they have been on aspirin prior to their stroke, I would just continue it as an 81 milligram because they already have it in their system. So it's not going to add anything extra. And we know that the high dose daily aspirin does not really add any extra benefit to the 81. If patients are already on aspirin, I wouldn't load. If they are not on aspirin before and I want to start it, I would load them. It's just a loading dose, right? So you just want to get it in their system faster. Because if you started with the 81, it is going to take some day for it to actually kick in.
But I thought the evidence, there was no clear evidence for this though. On a randomized control trial. It's something based on case series or stroke specialists who do this, right? This is not something supported on evidence, right?
It is.
Okay, so there is an evidence for people who are aspirin naive, you load them with aspirin. Okay, thank you very much. Yeah.
To begin, you mentioned some of the combination therapy. We have the COVID trial, the trans trial.
So they did look into it. It is a good option. It doesn't add extra benefit. Like I wouldn't take it as an option for dual antiplatelet, right? I would just take it as an alternative to aspirin if you want to. I know vascular tend to like it more for the peripheral vascular disease than us neurologists for stroke. So if patient comes to me on it, I will keep him if I need a mono antiplatelet overall as a plan. However, if I need a dual antiplatelet, I will go with the Plavix or ticagrelor for those patients. I don't think I would start it for my stroke patients.
Is the reason for that the side effect profile, or
it didn't show any extra benefit or any significant extra benefit in prevention.
Okay. So thank you very much, Dr. Adam.
You're welcome.
So I would like to introduce Dr. Osama Al-Bakr, and one of our most experienced neurologists. In fact, he's the head of the Department of Neurology at Jabir Hospital. He completed his neurology training at the School of Medicine in Miami, one of the largest hospitals in the United States, Jackson Memorial Hospital. And he had also a fellowship. He will teach us about the management of cerebral venous thrombosis. Please, Dr. Osama.
Good morning, everyone. Do you hear me? I'm presenting from a remote location. So I'm going to present this morning the topic of cerebral venous sinus thrombosis, which is a very relevant topic, especially during these days of the COVID-19 infection. As you know, cerebral venous sinus thrombosis is a subtype of stroke that you don't encounter in a daily practice. So it's not a day-to-day practice that you see a patient with cerebral venous thrombosis. And therefore, it can be missed or diagnosed late, and this is not good for the patient management. So the aim of this presentation is to be vigilant and aware of this stroke subtype, especially during the era of COVID-19. It has a heterogeneous clinical manifestation and not specific to the venous thrombosis itself. Imaging is the most important, especially MRI plays a primary role in the diagnosis. And if you diagnose it early, it has a favorable diagnosis. So that's why you have to have a high index of suspicion for the diagnosis. And the mainstay, as you know, is IV heparin or low molecular weight heparin. And as I said, in the COVID-19 era, you should always think about CVST in patients presenting with neurological symptoms or headache. So CVST is caused by complete or partial occlusion of the cerebral major vessels or the smaller feeding cortical veins. It affects women mostly. 75% of patients are females, and usually young because these are patients of the reproductive age. It rarely affects people in elderly people. So the incidence of cerebral vein thrombosis in patients over 65 years old is 8% only. And as we said, it's associated with peripartum period and oral contraceptives. I'm going to mention two studies that done in Kuwait, in Ibn Sina Hospital. They have over 10 years collected 71 patients, and those patients, the oral contraceptives was the primary risk factor in female patients, and early diagnosis and immediate treatment with anticoagulants reduced the morbidity and mortality. In this study, serum D-dimer is more helpful for early diagnosis with sensitivity of 58%. This study was extended after a few years and more patients were included. And the conclusion of that study is the headache, seizures, and focal neurological deficits were the most common neurological presentation. Anticoagulants were used as first-line therapy, even if there is intracerebral hemorrhage. The use of steroids and diuretics were used to decrease edema in 25% of patients, and those patients who had raised ICP were treated by serial lumbar punctures. CVT has certain risk factor, doesn't follow the classic atherosclerosis risk factor for arterial thrombosis. Around 13% of patients, they don't have any risk factor, can be identified. The risk factor for CVT can be divided into transient or permanent. And transient in those patients, women who is using oral contraceptives or during pregnancy and postpartum period, or certain infections of the ENT, especially mastoiditis. Permanent risk factors include the thrombophilia and prothrombotic states. The risk factor for cerebral vein thrombosis in a study by Ferro et al. Included, quickly we'll talk about those, gender specific, like the hormones, systemic infections like malignancy or inflammatory bowel disease or Behçet disease. Don't forget the Behçet disease. Always screen for Behçet by asking about orogenital ulcers, the genetic or thrombophilia. There are numerous infections, especially the ENT infections. Mechanical. Interestingly, CBT can happen after lumbar puncture. So be aware if the patient deteriorates after lumbar puncture that he may have venous thrombosis, head trauma, certain medications, and certain vascular, intravascular anomalies. As Dr. Badr discussed earlier, the pathophysiology of cerebral vein thrombosis is like the situation in idiopathic intracranial hypertension. There is a thrombosis of the veins and decreased CSF absorption, increase in the intracranial pressure, and disruption of the blood-brain barrier, and congestion of the veins. And there will be back pressure and hemorrhagic infarction. So this is peculiar for this kind of subtype of stroke. It's hemorrhagic. So it's very interesting that it's hemorrhagic, but still we're using the anticoagulation using heparin. For those who are not practicing this, they will be initially very surprised how we're using anticoagulation despite the presence of blood or hemorrhagic transformation. This is the hallmark of CVT, that the presence of hemorrhagic transformation, and anticoagulation should be used actually. So the more common presentation of the CVT is isolated intracranial pressure, as Dr. Badr mentioned, headache with or without increased intracranial pressure, focal symptoms like weakness, seizures, encephalopathy. Patient is usually have altered mental status. You see those patients, young woman who's drowsy, having seizures, headache, vomiting. If you see such patients, you have to suspect CVT. A rare presentation of CVT is cavernous sinus thrombosis, and that has a peculiar presentation with cranial nerve palsy, cortical vein thrombosis, subarachnoid hemorrhage. We saw several cases of subarachnoid hemorrhage as part of the CVT, and the cranial nerve palsy, like 6-nerve palsy, related to increased intracranial pressure. This is the cortical vein occlusion, where in this case there are several cortical vein thrombosed and appear hyperintense on MRI. When do you suspect CVST in patients with headache? Usually you ask, there is a history of using hormones, or patient just delivered, or there is a patient with malignancy. A new type of headache, different from the patient habitual headache. Symptom and sign phrase intracranial pressure, a new neurological signs, focal, decreased level of consciousness, or seizures. You have to be familiar with the venous anatomy, because this is will help you in diagnosing or identifying the location of the vein thrombosed. So in this case, this is the severe sagittal sinus, this is the inferior sagittal sinus, this is the straight sinus, transverse, and followed by the sigmoid, which eventually goes to the jugular vein. This is an MRV. This is a coronal view, back view. We see there is the severe sagittal sinus, drains into confluence of sinuses, both transverse sinuses, draining into the sigmoid sinuses, where there is the mastoid. If there is mastoiditis, it will cause thrombophlebitis in the brain and cause thrombosis. So you treat those patients with antibiotics. This is eventually the internal jugular vein. So the clinical manifestation occur depending on the location of the vein thrombosed. The transverse sinus is the most common sinus involved. followed by the severe sagittal sinus, followed by the sigmoid, then cortical veins and cavernous sinus. Cavernous sinus involvement is the least common. So transverse sinus location usually causes nerve palsies. Severe sagittal sinus will cause visual loss, aphasia because it's close to the speech centers. Sigmoid is a combination of several cranial nerves palsies. So you should know the vein involved and the subsequent neurological symptoms. Neuroimaging is very important in diagnosing patients with cerebral vein thrombosis. You can start with non-contrast CT. Is usually in emergency room, usually you start with CT scan. Can be normal in 30% of patients. There are certain signs that can help you diagnose the patients. MT delta sign and cord sign. You can see immediately the signs of ischemia by CT if the patient is presenting late. This is the classic MT delta sign. You see delta, which is a Greek letter, like a triangle. This is CT brain with contrast, should be with contrast. So you see filling defect within the distal severe sagittal sinus. And this is a classic teaching signs called the MT delta sign. You can see the cord sign on CT, which is a cord-like structure, can also make you suspect cerebral vein thrombosis. In this case, patient have bilateral venous infarcts, slight hemorrhage. Usually, if the severe sagittal sinus thrombosed, usually the infarcts are symmetrical or bilateral. Such patient will present with altered mental states and aphasia and seizures. CT venography or CTV. So if you see this patient in the ER and you see such CT, you should ask for CTV as an initial test. It has a very good diagnostic accuracy, high sensitivity, and specificity. It can show absent flow in the thrombosed vein or sinuses. And however, there is false positive. It can, certain venous anatomy is not as variable, and certain patients have congenital hypoplasia, and this may give you false positive venous thrombosis. Usually the venous infarcts are hemorrhagic, like in this case, can be bilateral. That is, here you can see thrombosed transverse sinus or thrombosed severe sagittal sinus. MR venography is the standard of care, and you can do it without contrast. Again, the high risk of false positive because of the variant. Actually, we see a inexperienced radiologist or inexperienced person dealing with such cases will overcall the case as cerebral vein thrombosis and unnecessary anticoagulation. So you should take this into the context of the patient diagnosis. You can do MRV without contrast in the time of flight or phase contrast. Contrast enhanced MRV needs contrast, of course, and this is more accurate and overcome the difficulty with the venous hypoplasia. The MRI is very sensitive. It can detect recent infarction by DWI and give you more details about the extent of infarct. This is how the deep infarcts look like with the hemorrhage by susceptibility weighted images. Beware of the hypoplasia, the chronic thrombosis. Some patients will have partial recanalization, but will not, if they have history of CVT in the past, they will still be, it will show later by later imaging. We rarely use the digital angiography. We don't use angiography for diagnosis. Only if there is isolated cortical vein thrombosis or there is associated dural AV fistula, you can use the digital subtraction angiography. The management of CBST includes looking for the etiological cause, starting anticoagulation, and symptomatic treatment of intracranial hypertension, seizures, or other complications. This is briefly the American Stroke Association guidelines. You should start with the routine blood tests, look for prothrombotic conditions, postpone the thrombophilia workup until 2 to 4 weeks after completion of the course of anticoagulation. That means after several months of this, stopping the anticoagulation. Provoked CVT usually needs a course between 3 to 6 months. Provoked means after using oral contraceptives or after pregnancy or after delivery. If there is unprovoked, you should extend the course of anticoagulation to 6 to 12 months. If you have a patient with a current CVT or you identify a definite cause for thrombophilia, this patient needs indefinite anticoagulation. You can use low molecular weight heparin during pregnancy until 6 weeks postpartum. And you tell the patient that future pregnancy is not contraindicated. And you can use prophylaxis with low molecular weight heparin during pregnancy. D-dimer is used often for diagnosis of deep venous thrombosis or CBST. You can use D-dimer mostly as exclusion because it has high negative predictive value. So it's if the patient have only headache and he's fine, his CT is fine, and you do D-dimer, then you'll be more assured that the patient most likely will not have CVT, and you don't need to do further unnecessary testing. Anticoagulation, we said between 3 to 12 months, depends if this is provoked or unprovoked. There is no definite guidelines regarding whether you have, before stopping anticoagulation, whether you do follow-up CTV or MRV. There is, it won't change really the management. And there is no mention of the use of antiplatelets after CVT. Anti-epileptics are used with supratentorial lesions or if the patient presents with seizures, and those requiring longer-term anti-epileptic if there is a residual lesion. This is, in summary, the algorithm for patients with CVT. So if you ideally should do MRI. If you cannot, you do CT, CTV. If you don't find CTV, look for alternative diagnosis. If you confirm it, then you start your anticoagulation. Patient improves, then use the anticoagulation for several months, then stop. If the patient deteriorates, then think about decompressive craniectomy or interventional radiology. There is a trial about use of dabigatran. Of course, you'll think not only warfarin will work for such patients. So new oral anticoagulants can be used. So in this case, a study about dabigatran 150 milligrams twice daily compared to warfarin. And the study showed it's both are safe and cannot be, we cannot demonstrate non-inferiority or superiority of either treatment. There is ongoing study about the use of rivaroxaban compared with warfarin. to see if there is any still works like dabigatran. The duration for anticoagulation still need to be defined exactly. So there is ongoing trial about the benefit of extending oral anticoagulation treatment after CVT, and the XCOA trial is still going regarding the definite duration of anticoagulation. Endovascular treatment is used rarely, as we said. It has a rate of intracellular hemorrhage of 10%, little bit higher mortality. Thrombolysis is not used. We only consider endovascular treatment in severe cases, like those who do not improve with anticoagulation, and especially if you do the intervention early in the course of the disease, not late. This is hemicraniectomy. You see here there is a big hemorrhagic infarct with midline shift. In this case, the decompressive craniectomy helped the patient, saving the patient from herniation. The prognosis, overall prognosis, is improving. And a third of comatose patients have a full recovery. This is the last part of the talk about CVST and COVID-19 infection. As we know, thromboembolism is part of the COVID-19 infection, and a hypercoagulable state can be seen late in the COVID-19 infection, even if
Dr. Osama, 1 more minute remaining.
Okay. Then the patient can present late due to potential association. We'll talk about the vaccine. As you know, the Johnson vaccine and the AstraZeneca were associated with a new vaccine-induced prothrombotic immune thrombocytopenia. This is a rare and a new syndrome. It's called VIBIT or TTS, and the patient have present with CVT, and that's why the CVT gain fame during these days. The patient will present with headache or abdominal pain if they have splanchnic venous thrombosis, visual changes like CVT. And it's so uncommon. It was not observed during trials, observed when the actual vaccines started. So it's very rare, like less than 1 in a million. So the American Stroke Association, American Heart Association advised to continue to urge everyone to get vaccination, but beware of those who have hypercoagulable state and older patients. And definitely the benefits of vaccination far exceed the very small rare risk. In summary, CVST is rare, but clinically serious and can result in substantial morbidity and mortality. The causal factors for arterial thrombosis is not there, so you have to suspect it. MRI plays a primary role. COVID-19 should be considered as one of the differential diagnoses of cerebral venous sinus thrombosis. The likelihood of developing CVST after a vaccine is extremely low, so you better get vaccinated to protect against all the complications of COVID-19. Thank you so much.
antiphospholipid, everything's good. Thank you. Amerantic endocarditis or LV thrombus. And then there are those case-based scenarios that not everyone will be a candidate for anticoagulation. It will just depend on the expert opinion and what you usually would do in those matters. Something like unstable plaque, or if there's a free-floating thrombus, personally, I would anticoagulate those for a short-term period. If we think this stroke is related to hypercoagulable state, like an active cancer with high D dimer, and even now in patients with COVID who have had COVID-related stroke. And those patients who will need anticoagulation for other reasons than their strokes, but we cannot continue their anticoagulation due to their stroke in the acute phase period. Just remember, majority of the evidence that we'll be talking about has been driven from AF-related strokes. So overall, balancing risk and benefits for oral anticoagulant has been for the long term rather than for the acute term of or short term of when we start those anticoagulation immediately after a stroke. So the risk of embolization have been overall balanced between clinical features like previous history of stroke, TIA, diabetes, old age, hypertension, and there has been some evidence that even the longer you are in atrial fibrillation, that will predispose you more to having a stroke related, and some echocardiogram features that will just make them more prothrombotic overall from atrial fibrillation. And this has been transferred into CHADS-VASc risk criteria or CHADS-2 or even CHADS-65, depending which region you're going to talk about. And accordingly, there has been a calculation. But again, remember, this calculation is annual. It's a year base and not necessarily for the acute phase after. Bleeding risk, again, it depends on the choice of anticoagulant that we choose to start them on, whether it's going to be a DOAC or vitamin K antagonist, how we started, the role of bridging beforehand, the dose is appropriate or there's supratherapeutic on it, and some patient-related, like we know elderly, Asian, those with prior bleeds and certain bleeds and certain comorbids like liver disease, kidney, concomitant antiplatelet medications with anticoagulation, thrombocytopenia, all of those will predispose them to having a bleed. This again has been translated into a different scoring system, but just remember those scoring system, none of them should overrule your clinical judgment as a physician on how much the patient needs anticoagulation versus the risk of having a bleed related to those anticoagulation. Then again, those criteria, has blood and atria and all of those scores doesn't really necessarily focus on intracranial bleeds, which is what we care about as a neurologist overall, because that seems to be associated with the highest morbidity and mortality when we talk about anticoagulation related to bleeds. So factors like history of prior stroke, uncontrolled hypertension, CAA, having cerebral microbleeds, intracranial vascular malformation, brain tumor, history of drug abuse or falls, endocarditis, all of those will predispose them to having more bleeds. This is an interesting case control study that was published this year, actually. They tried to look into DOAC and the risk of intracranial hemorrhages. So they took those AF patients on DOAC who have had bleeds, intracranial specifically, and compared them with those AF patients on DOAC for more than a month without a bleed. And they found that the older they are, hyperlipidemia, creatinine clearance, concomitant use of antiplatelet therapy, and white matter changes have been significantly associated with increased risk of intracranial hemorrhage. Interestingly, neither CHADS-VASc nor has blood scores actually worked on those NOAC patients in predicting their risk of having future bleeds. Now, going back to atrial fibrillation and stroke, so we know anticoagulation will reduce lifetime risk of recurrent stroke in those patients from 12 to 4%. In the acute phase, we always need to balance between the risk of having hemorrhagic transformation and having recurrent stroke. This is the highest for both in the first 2 weeks. It's thought to be 1.3% per day for the hemorrhagic transformation and 0.5% per day for the recurrent ischemic strokes. Just a reminder that not all strokes are the same. So we have those perforator strokes that can be small and they don't necessarily have a higher risk of hemorrhagic transformation compared to embolic. MCA strokes also could happen in different sizes. So not just when you say MCA stroke, that means you have to delay anticoagulation. Sometimes a stroke is so small and will qualify for an early anticoagulation. And a quick reminder of hemorrhagic transformation classification based on ECAS-2. So we have those A and B, which are hemorrhagic infarction 1 and 2, and we have C and D, which are parenchymal hematomas. And those usually the ones that tend to be symptomatic. And again, when we say symptomatic, we usually mean increase in IHSS score of more than 4. The overall incidence of spontaneous hemorrhagic transformation on autopsies had been up to 70%, whereas on CT alone up to 43%. But remember, again, the symptomatic ones up to 20% only. And we know there are certain risk factors that will predispose those patients more so to have hemorrhagic transformation. Again, sometimes as an evolution course of the stroke itself, that they would have hemorrhagic transformation. So it's not necessarily a mistake or something went wrong through the management of patients, but factors that we can help out in reducing this risk is predominantly controlling the blood pressure. I don't want my patient to have very, very high blood pressure throughout his course in hospital. We usually just keep that blood pressure labile for the first 2 days if they did not take any acute reperfusion like IV TPA or thrombectomy, and afterward, we lower it gradually. For those who have had acute reperfusion management, usually we target less than 180, but the same thing, we also lower it gradually. And this will specifically matter after we start the anticoagulation, how strong we need to control blood pressure. Quick reminder that all the large DOAC trials, RELY, ROCKET, RSTOL, ENGAGE, none of them actually have included patients with acute stroke. They all excluded patients with recent stroke from 1 week after the stroke to 6 months after their stroke. So those patients were not really part of those studies. And unfortunately, when we try to look into our evidence as anticoagulation after ischemic stroke, you'll notice that most of our evidence have been observational and retrospective. The two large ones that I will focus about by Dr. Bacchironi and his colleagues, RAV and RAV-NOAC. So regarding RAF, this is a prospective observational study in Europe and Asia that looked into patients with acute ischemic stroke and atrial fibrillation who will need anticoagulation and they don't have any contraindication for it. The study outcome predominantly has been for looking into ischemic events, so that's recurrent ischemic stroke, TIA, or symptomatic systemic ones, and looking into also symptomatic cerebral bleeding or major extracerebral bleeding. This study included approximately 1,029 patients. Of those patients, 74.4% treated with anticoagulation and the rest did not receive anticoagulation. Looking into how they divided those anticoagulation among those patients, you find that approximately 37% received warfarin from those patients, and interestingly, 36% received low molecular weight followed by vitamin K. So there was some bridging going on in this one. The overall hemorrhagic transformation in those patients in this study has been approximately 13%. Patients who have received reperfusion therapies, 22.4%, and only 16.1% of those have had hemorrhagic transformation, of which 6.1% was parenchymal hematoma. And again, those patients who have had an outcome, whether that was a bleed or ischemic, compared to what I just said, has been 11.7 in those who received anticoagulants and 14.4 in those who did not receive it. And if you look into the ischemic specifically, you find that they actually do better if you do start them on anticoagulation with a p-value of 0.023. Now, the mean time of when they were starting the anticoagulation after the stroke has been different depending on the agent that was used. You'll notice it was the shortest for those with low molecular weight heparin, and for vitamin K antagonist seems to be the longest. Now, for predictive factors that will predispose to any outcome, so the severity of the stroke, NIHSS, has been associated. The size of the stroke, the larger the stroke, the more likely they will have an outcome associated. Similarly with the Chad-Vasquez stroke as well, Chad-Vasquez score, and if they have had any bridging going on. Now, specifically for the ischemic outcome, they noted that the age and the large stroke has been associated. And regarding the hemorrhagic outcome, again, they noted that bridging has been associated and the size of the stroke also has been associated. Then they tried to look into the timeline of when those anticoagulation have been started after the acute stroke. So during that time period, they noted that the outcome have been reduced for those who were started between 4 and 14 days. Specifically, the ischemic outcome has been less for those patients. Then RAF-NOACs, again, by similar to group, also including Europe, United States, and Asia, another prospective observational that looked specifically for AF and acute stroke who were started on DOAC. So this one had included approximately 1,127 patients. The distribution between dabigatran, rivaroxaban, and apixaban has been the same. At the time of this one, edoxaban has not been out yet and commonly used, so it was not really quite included. 62.7% did receive antiplatelet until it was thought to be okay to be started on anticoagulation, and 9.6% still received low molecular weight bridging for those patients. only 2.2% were treated concurrently with NOAC and antiplatelets. And again, hemorrhagic transformation on imaging seen in 9%. So overall, 5.2% have had an outcome, of which 2.8 were ischemic and 2.4 were bleeds. But you notice that the overall outcome for ischemic and hemorrhagic for those like NOAC had been 60% lower than the RAF population that has included vitamin K antagonist. Again, when they try to distribute it by time, whether we started within 2 days, within 3 to 4 days, or after 14 days, the best benefit for reducing risk of outcome had been for those who were started between 3 and 14 days with 2.1%, whereas if you started earlier, it will be 12.4%, and if you started later, will be 9.1%. When they tried to look specifically into each factor, they couldn't really build any unbiased opinion over which one will be better and which one will reduce the outcome better. The percentages overall seems to be variable, but there has been nothing significant in those numbers. IAC is a more recent, was published last year, another multi-center retrospective collaboration for anticoagulation after stroke. They had two main targets. They wanted to look into the role of bridging and trying to compare between DOAC and warfarin. And the outcome, again, similar had been for recurrent ischemic event and delayed symptomatic ICH. So for those, when we tried to compare DOAC with warfarin, they had approximately 1,251 patients. Of those, 69% were on DOAC, and majority of those have been on factor 10 inhibitors. And what they found was that the recurrent ischemic events have been less in those on DOAC compared with warfarin. And the delayed symptomatic ICH, there was a trend for less with DOAC, but it was not clinically significant. This is again the similar group IAC as well. They tried to do it by based on timeline differentiation. So they did 0 to 3, 4 to 14, and more than 14. And predominantly of those have been therapeutic anticoagulation as 0 to 3. But again, similar thing, they did not find significant difference in composite endpoint between the three groups. So it didn't really have any significant results on when those were started. What they noted, however, it was like the timeline after, the timeline was kind of still going in between those 4 to 14 that seems to be doing better. This is just a quick reminder of this new publication, REST study. That was the first RCT that looked into apixaban versus warfarin for acute stroke and indication for anticoagulation with AFib afterward. Unfortunately, none of those have been positive for numbers. Again, there was a problem with the warfarin dropouts from that group. So further problems when the guidelines in 2019 came that have recommended starting with DOAC over warfarin. So it was not appropriate at that point to enroll more patients into the warfarin group. Now, this is another prospective multi-center, but it was interesting because they tried to compare the timing of starting anticoagulation for anterior circulation stroke versus posterior circulation stroke. So they had about 473 patients with posterior circulation stroke, and they compared it with RAF and RAF NOAC population of anterior circulation stroke that has been about 1997 patients included. And in this one, again, they did not find a significant difference between the two groups regarding all types of outcome. So ischemic or bleed whatsoever between the two. What they did find, however, is that the most benefit would happen within the, like after 10 days if you started. Now, if you try to compare, I think if I use the mouse, something will pop. Let's just, okay, pop good. So if you try to compare here between like the 8 and 14, for the combined outcome, it was 8% in the anterior circulation, and the 8 to 14 it was 6.8% for the posterior circulation. If you look for the ischemic, it was 3.4% for the posterior circulation, and it was 3.8% in the anterior circulation. Again, looking into the 8 to 14, 3.7 for hemorrhagic, and it was somewhat higher for those with posterior circulation. Then they tried to look into the size of the stroke. So those more than 1.5 centimeter considered as a large stroke, and small stroke less than 1.5 centimeter. And they found that the larger the stroke, the higher the chance of having hemorrhagic endpoint. This is just a quick reminder that they also tried to look into starting anticoagulation for patients who have received acute reperfusion, and they did not find that it would increase the risk of having a bleeds or a change in their outcome afterward. So we can still keep in mind the same time window we have if this patient had received IV thrombolysis. Now, the question of bridging, this is a combined paper between both RAF and RAF NOAC population, and they tried to look overall the benefit of bridging. So they took those from each group and put them together, and they did not, the result was significant where the outcome overall combined had been increased. So there was really no benefit of bridging. Both ischemic outcome and hemorrhagic outcome had been increased for those who had received the bridging prior to anticoagulation with oral agents. Now, IAC, as I mentioned earlier, also looked into it. So approximately 203 patients were started on bridging in this population. And the median time from starting the bridging therapy to initial oral anticoagulation was shorter in those with warfarin. But similarly, I think you notice that the delay in the time to delayed symptomatic ICH was actually higher in those who have been started on bridging without difference in lowering the ischemic outcome. So it just added more bleeds without any benefit. Now, guideline-wise, talking about what we have so far as a recommendation, AHA publication had been in 2019 again, and they just recommended between 4 and 14 days. In the Canadian Stroke List Guidelines, which is unfortunately the oldest of all the guidelines, is stuck with the 1, 3, 6, and 12 rule of 1 for TIA, 3 for mild stroke, and 6 for moderate stroke, 12 for severe stroke, emphasizing that we don't really know. EHRA guidelines, so initially they just went with 1, 3, 6, and 12, but interestingly, more recently, they made it more practical. So now they focus on the importance of the brain imaging, the importance of having hemorrhagic transformation already, if there has been any change in the clinical presentation of the patient, if they have had any clinical worsening throughout, and accordingly, they just mentioned like a graph on how we can go ahead. And this is all like just something based on expert opinion. ISO recommendation used to be 4 to 14 in 2016, but more recently, they just acknowledged that in reality, we don't really know, and they emphasized the importance of enrolling those patients in RCTs. This is the best for non-neurologists, I think, because again, it gives an idea about the NIHSS and how we can calculate the severity according to, and some factors that will prompt us to starting anticoagulation early versus some factors that will prompt us to delay starting anticoagulation for those with stroke. This is a Korean retrospective that tried to see if there's any change in outcome if we do follow European guidelines of 2016 that I just mentioned. And interestingly, in this one, they did find that actually ischemic stroke better. So even though our recommendation had been expert opinion, they do work. Now, having a stroke in spite of oral anticoagulation in this 7 prospective cohort studies put together, they found approximately 1,195 patients were on anticoagulation and have had acute stroke or TIA. And those patients who have had a stroke on prior anticoagulation, they usually have had higher cardiovascular risk factors, even though their CHA2DS2-VASc score and HAS-BLED score have been the same. And changing that anticoagulant agent after the index event was not really associated with decreased risk of further ischemic stroke. So overall, those patients tend to stroke because number one, for me is those oral anticoagulant agents, they don't prevent a stroke 100%. Just remember that strokes happen overall. One cause is atrial fibrillation, but it's not the only cause. And even for those atrial fibrillation related strokes specifically, it's not a 100% prevention for those. And sometimes there will be a non-compliance issue, there will be a drug interaction issue. And if the dose was not appropriate, which seems to be one of the biggest issues that I've seen so far, unfortunately, especially with NOAC. Remember, just because your patient looks frail does not mean he will qualify for apixaban 2.5. You actually care about the age, creatinine clearance, and the weight of the patient before we say this patient will benefit. Think about it on the long term. If you get this patient back in the future with a stroke because the 2.5 was not sufficient, you cannot give them TPA because they already have some anticoagulation in their system that's not sufficient. You gave them this because you thought this patient was frail, and then you're limiting yourself with the option of thrombectomy because not all interventionists will be welcoming taking a patient with MRS of 3 or 4 for thrombectomy stroke. And technically that stroke could have been prevented had the patient had a full proper dose of anticoagulation. Now, those two just information here mentioned that, again, it's a 1% year risk of having embolic stroke on warfarin, 1.4 for NOAC. And Lipital paper actually identified coronary artery disease and smoking as additional risk factors for thromboembolic in those patients anticoagulated on for atrial fibrillation. And this is just a quick reminder, again, that there is no evidence that we need to add aspirin for those patients if they stroked on anticoagulation or whatsoever reason from stroke perspective. The only exception I would say is if the patient have a stroke with symptomatic severe carotid stenosis, that they will go for carotid intervention. I would probably keep them on aspirin and anticoagulation prior to their intervention. So now for aspirin, until it is safe to start them on anticoagulation, we don't really have a big data to tell us what we're supposed to do. IST and CAST trials have been like an old one that showed that aspirin will reduce the risk of future stroke overall, regardless of the cause. We know that aspirin does not prevent a stroke for atrial fibrillation, like it's not an option for atrial fibrillation specifically. However, because as we said earlier, those patients also have other risk factors, and stroke does not necessarily happen only due to atrial fibrillation. I do think it's reasonable, and even with the ESO expert opinion, that it is good to keep them on antiplatelet until it is safe to start them on anticoagulation. And with ERA as well, they emphasize that if you think the stroke happened on anticoagulation, you remove the anticoagulation, you start the aspirin, and you start it once you think this anticoagulation is out of their system so that they don't get any sort of dual antithrombotic until then. Again, just a reminder, we don't recommend aspirin or combination for stroke prevention atrial fibrillation, especially after DOAC and after apixaban with almost similar risk of a bleed. So it just doesn't make sense at that time to start them on aspirin. We do have some ongoing trials that's looking for starting anticoagulation after stroke, specifically looking for those with DOAC with different time window to try to help us when is the best time to actually start them. In conclusion, we know that anticoagulation will benefit those patients with a stroke and atrial fibrillation in order to prevent more strokes. We just don't know yet when is the best time. We definitely don't want to do any bridging before we start them on their oral anticoagulant agents. And while stroke on anticoagulation tend to be milder and tend to happen, there is no absolute indication to change it to a different agent. Not necessarily right, not necessarily wrong. We just don't have an evidence on what we're supposed to do for those right now. So it is okay if we just want to continue the same DOAC, assumingly that they are at the appropriate dose and the appropriate choice of anticoagulation. Thank you very much.
Thank you very much. That was a very informative and updated lecture about the use of anticoagulation after stroke. We have few questions. We have 5 minutes of discussion, then we'll break at 12 noon for the Friday prayer. So let me start asking if Dr. Osama Al-Bakr is with us. There is a question about the use of seizure medication, anti-seizure medications in patients who had cerebral venous thrombosis. Without having seizure, like just the fact that they had venous thrombosis, would you use anti-seizure medication for that? Dr. Osama. Okay.
I think he's answering, we just can't hear him.
Yeah, okay. Okay, he's here.
Dr. Osama is not available in the panel, doctor.
Okay, that's fine. So we will direct the question maybe to Dr. Adari. The use of anti-seizure medication, they use anti-seizure medication people who have cerebral venous thrombosis without having seizures at all. So what do you think of that?
So technically, we don't have any strong evidence to say we can use anti-seizure medication prophylactically for those patients. If you work in a center where you don't have like a 24-hour EEG coverage or just like limited EEG coverage, and I cannot be 100% sure, level of consciousness of the patient is down and I cannot rule out non-convulsive, in that situation, I would be comfortable to start empiric anti-seizure. But otherwise, if the patient is awake, alert, I probably wouldn't.
So another question here, there is a question about the indication of combining antiplatelets and anticoagulation in patients with ischemic stroke, like you use both agents.
So again, as a neurologist, from stroke perspective, we usually do not combine aspirin and stroke. I know some expert opinion, they would do it if they thought there is a significant intracranial athro, they would do a short term of both. But again, the risk of bleeds with those usually tend to be higher. The benefit is not 100% proven for those, especially after having like those a trial with WASID, warfarin versus aspirin or so. The one indication that I would emphasize on again is just if a patient is going to go for carotid endarterectomy, in that situation, vascular and we as stroke neurologists also, we like to combine those two. So yes, that's actually one of the challenges now, especially with COVID, and patient is pro-coagulable. So they will get the STEMI, they will get the stent, and then they will get the stroke, and they want everything. Especially if they had like an unfortunate rapid AFib immediately before to go to their CAT, which is an actual patient that we have right now. So we have to balance everything out, right? So what I would recommend in that time period, if I'm going to do the anticoagulation only for AF, not for any other indication, I would follow the rule of 4 to 14, depending on the severity of the stroke. The antiplatelets, I will be more comfortable with it. I would do the dual antiplatelet. That's okay for me. And if I want to start the anticoagulation, then I can start, depending, of course, on the choice of anticoagulation, I can add it later on in the future. I wouldn't have necessarily like a no, but it will depend on the size of the stroke. Like if I had a malignant MCA and I would usually have stopped there for like 2 weeks and this patient have had hemorrhagic transformation and I want to do all that triple therapy, I still can, but I wouldn't feel very comfortable to do it acutely. So that means I'm just going to delay the time of anticoagulation because cardiac stent will win over and we still need to do the dual antiplatelet for those.
One last question before we break. There is a question about the use of anticoagulant, like within the after stroke, within the period of 4 to 14 days, for someone who already has received TPA. So, would you do that? That's the question.
Yeah, that's similar to one of the studies I showed that they did not find there's any increased hemorrhage if you stick with that rule for patients who have received TPA. Remember, TPA is a short acting. It doesn't last in the system for a very long time. Just those patients who have received TPA tend to have a higher risk of hemorrhagic transformation. So you just want to make sure that you have a frequent follow-up imaging and clinical assessment to make sure that they don't have a significant one. And accordingly, you will just give anticoagulation.
Okay, one more question by Dr. Jassim.
Now, two scenarios actually which are very difficult. Intracerebral hemorrhage, patient with intracerebral hemorrhage, and you want to anticoagulate for a reason. For example, like a mechanical valve. So how the intracerebral hemorrhage will when do you start anticoagulation in a patient with intracerebral hemorrhage, especially when those people have a thrombus in their heart sitting in their atrium or intracerebral hemorrhage? Please, if you can update us on this.
So another unfortunate encounter that we also have had quite a few of those with COVID. Again, we don't have a clear guidelines. We don't have a clear RCT to tell us when we can start anticoagulation or antiplatelet for those patients. The best we have was START, which tried to look into antiplatelet after ICH, and they thought it would be it would be appropriate to start them after, I think the median was 4 days for those patients. Regarding anticoagulation, you kind of want to wait for at least a month, but if the indication is something that significant, it will depend on the size or the volume of the hematoma that they have, the location of that hematoma. If I can do a CTA to predict if they have like a leaking vessel, so that will just increase that hematoma from expanding further, I would do those. I would still start them as early as the size would allow me to. If I needed them to be started earlier, what I would do at that point is just very frequent imaging for those patients. I will avoid them to be like super therapeutic if they were started on low molecular weight heparin. Like I would just do a low target for them instead of that time being. And we'll see where it goes. But there is no absolute right or wrong answer. It's really just a matter of balance between the two.
Okay. Thank you very much. I would like to thank all of you for staying with us until this time. Let's reconvene at 1 o'clock. We'll have the satellite, the interesting satellite symposium at 1 o'clock about emgality. So please join us back at 1 o'clock. Thank you so much.
Lunch will be ready at 12:30. 12:30 lunch will be ready.
Check this 1, 2, 3.
Hello, friends. We hope you all would have received the email with the link kuwaitneurology.com/webinar. So I will be taking you through a demo as to how you will be using this webinar. To begin with, this is our home page, the main page. As you see on the left side, you have watch webinar on the YouTube and join the conference. And the conference is day wise. Friday, the first day at 9 a.m., you will be able to click here and join the conference. We have to remember that you have to use your email ID, the same email ID that you used during registration. It's very important because you'll be getting your CME by using again the same email ID. So the email ID, please ensure that you use the same email ID throughout all the both the days that you join the conference. Now at the center, you will see, in case those of you who have not yet managed to register and would like to register, you can click here and register yourself. When you will click here, you will see our booth. There are 5 booths. You can go to any one of them and register. It's a very simple registration form that you have here, wherein you put in your basic information, your first name, your last name, your title, your hospital name that you are in, the specialty, email and phone number, and you will click submit. Now, after you complete registration, you will be able to join the conference. Now, besides that, I'll take you through all the other details that we have on the page. On the left side, you have your speaker details that you can scroll and go through all your speakers. At the same time, you have the scientific program mentioned. You can scroll and check out your entire day's schedule. We have the chairman's message. Now we come back to the most important part of the exhibition, which is the medical exhibition. We've tried to give you a real life experience by having this virtual 360 tour, and we hope you will all like it. You can click here to go through the tour. So here you will see that we are in the lobby, and please click on this sentence which says experience 360 tour of the medical exhibition. Please click here. Once you click here, you will be able to see the entire lobby of the conference, where we have mentioned all our diamond sponsors, gold and platinum sponsors. Now, I'm sure you'd be all interested in going through the exhibition hall. Of course, here we have the scientific program, which is again on the main page. But now I'll directly take you to the exhibition hall. We'll first go through our diamond sponsors. So this is your diamond sponsors. Like for example, we have Sanofi. You will see that there are these information details here. You can click on any of them, and you will see that there you have their brochure. Their information is mentioned, right? Now you'll be also, there are these icon will say it's a video. So this is a video, for example. You can view their video also. Similarly for Novartis. Now the very good thing about this is you will also be able to view their videos. At the same time, you can also download their information. Like this is an icon where you can download and save it on your PC or laptop by clicking here. Yeah, so you can click here. Same thing, we have Lily. have biologics. Feel free to explore. The best thing about this exhibition tour is you can watch it at your convenience, and it will be open on both the days throughout. There is no time constraint, so even after you complete your lectures, you'll be able to watch the videos and you'll be able to download their brochures and catalogs. Now, once you complete viewing the diamond sponsors, you can go to the platinum and gold sponsors. They are both in one hall. You can click here. We have the same thing here, but you can click on any information you like, or you would like to know more. Please feel free to click on the video to see all that they have to tell us. I'm just taking you through all the booths one by one. Yeah, so I think we started with Novartis. So we are done. Once you have you have gone through the exhibition in detail, you've done your downloads. You can simply, and you finish watching the entire floor, you can simply click here and close. So you will come back to the main page that you started from. Now, the most important thing is, once you complete on your both the days, you can come back after 3 working days to claim your certificate on the same page. You'll get an icon somewhere here mentioning claim your certificate. So you'll need to enter the same email ID that you used during registration, and that's how you will get your 11 CME certificate, inshallah. So we hope you enjoy your conference on Friday and Saturday, both the days, and we wish you all the very best. Thank you very much for your patience and for being with us for the entire demo session. Thank you.
Another thing you can count on, assuming your condition and housekeeping.
Hello, everybody. My name is Piero Barbanti. I am the president of the Italian Association for Research on Headaches, and I work at the University and Scientific Institute San Raffaele in Roma. And my topic today is to discuss with you the results of galcanezumab in real life, comparing the data we found in these trials with those of randomized controlled studies. Here you see my disclosures. And the first question I want to address you is, why do we need real-life studies? We need because we have to translate efficacy into effectiveness. We have to test and to confirm the safety and tolerability of a given drug.
I checked there is.
That is not top. Not top.
Yeah.
Because it is connected that way. Okay.
Well, I'm focused on this one.
No, no. Only this one. Hello, hello.
This one there.
What are you? It's okay. No. Bibi. That's why not.
But the problem is not in the Zoom.
Hello. അതേനാ തെയ്യുള്ളൂ. ഹലോ ഹലോ. കേബിൾ അങ്ങോട്ട് കൊടുക്കണം. Both are mathematics. Both are mathematics. No. Hello, mic testing. Hello, hello. Hello, mic testing. Okay, okay, that I don't know. Oh, now okay, this mic. Second one, wait. Wait, second one. Hello, mic testing. Hello. Hello, mic testing is good voice. Okay, this two okay. Okay.
No, if they ask only mic, you can give this one.
Hello. Hello.
ഇതെല്ലാം സ്പീക്കറാണ് ഓക്കെ ഇത് രണ്ട് മൈക്ക് എല്ലാം സ്പീക്കറിലേക്ക് വരും
Hello? Hello? Hello?
Share the screen. Which one the presentation? This one?
Yeah, there are several posters.
Please.
Yeah.
If you hide that one, I will do.
Yes, doctor. Are you ready? Yeah. You can.
It's playing go live. Yeah, we'll start. Anything, we'll start now. You get you. You ready to? Are we live? Or? Inspector Ismail, you want to check if we are? So good afternoon, everyone. And thank you for being with us for the afternoon session for the first day of the 5th Kuwaiti Neurology Conference. I would like again to thank the people, the speakers, and the participants, and the people behind the scenes, actually, the IT people. There are many people here, probably there are more than 10 people working to make this event to be conducted in a nice way. As you know, wherever you go, anywhere in the world, you will find a technology problem and internet difficulties, but hopefully we deliver the knowledge with our best for different people, general practitioners, neurology resident, seniors, people, consultants, with the best updated knowledge. So we'll start first with the satellite symposium. I'm gonna moderate this session. I'll take the question at the end. This is a Lilly conducted symposium regarding galcanezumab with acute, the data and the world evidence data from Italy for the acute and preventive therapy. And then I will take any question regarding the satellite symposium.
Hello, everybody. My name is Piero Barbanti. I am the president of the Italian Association for Research on Headaches, and I work at the University and Scientific Institute San Raffaele in Roma. And my topic today is to discuss with you the results of galcanezumab in real life, comparing the data we found in these trials with those of randomized controlled studies. Here you see my disclosures. And the first question I want to address you is, why do we need real-life studies? We need because we have to translate efficacy into effectiveness. We have to test and to confirm the safety and tolerability of a given drug. And at least to me, above all, we have to look for some predictors of the response, but in a population which is real life, which is characterized by multiple comorbidities and very often by multiple prior therapeutic failures. So I want to show you the GARLIC study. GARLIC is an acronym that means galcanezumab in real life in Italy. This is a multi-center study, involved 6 Italian headache centers covering 4 Italian regions. Is a prospective cohort real-life study. We enrolled 81 patients aged 18-65, and we consider those episodic migraine patients having at least 8 days per month. That means high-frequency episodic migraine patient and chronic migraine. We use galcanezumab with a standard loading dose of 240 milligrams, followed by 120 milligrams each month in the following administration with a subcutaneous injection, obviously. And the trial lasted 12 weeks. Patients were allowed to continue their concomitant prophylaxis if the patient was treated with standard of care. This is a population we studied. As you see, is a typical population which is afferent to a certain tertiary referral center, mostly females, 85%. You see the monthly migraine days, 11 days for episodic, 20 days for chronic migraine patient, a very high number of monthly analgesics, and you see also very high disability as measured by the HIT6 and MIDA scores. But please, I want to focus your attention on the last row. 70% of the patients we treated with galcanezumab in the GARLI study had failed at least 4 prior therapeutic treatments.
Professor Barbanti, the clinical characteristics of the patients included in the GARLIT were very similar to those of the population that was involved in the clinical trials with galcanezumab. What can you tell us about the results in the GARLIT study in respect to what we observed in the clinical trials?
Let's now have a look on the similarities and differences between the GARLIT study and the RCTs EVOLVE 1 and 2, which were performed on patients suffering from episodic migraine, REGAIN, chronic migraine, and CONQUER, both episodic and chronic, but with 2 to 4 prior therapeutic failures. Obviously, the sample in our study was much less, 81 patients, but the primary endpoint was similar, was the same. That means the change in the monthly migraine or headache days at the end of 3 months in this case. And here you see our results, which are very interesting, which are also, let's say, at least in line with what described in the RCTs trials. You see a change, a reduction by 8.5 migraine days in the episodic migraine patient, and by 11.5 in chronic migraine. This also obviously implies a reduction in monthly analgesic intake. And please note also the reduction in pain intensity. This is a feature, an aspect that we do not very often capture in the trials, but is very meaningful actually for the patient and also for us. But we have to put probably more attention on this aspect. I will explain better this point later on. And as you see, we found also a substantial reduction in HIT6 and MIDAS. We found a statistically significance for all these items, but the patient with chronic migraine who showed a reduction in MIDAS score did not reach the statistical significance. I will explain again this point in the next slide. Here we see the results in terms of reduction in monthly migraine days compared to baseline in the GARLIT real-life studies compared to the RCTs trials. And as you see in episodic migraine with high frequency, at least 8 migraine days per month, this was the population of episodic migraine patients we considered, we found a reduction which was much higher than that reported in the prior trials, because we found reduction by 8.5 days at 3 months compared to roughly 4.5 in the EVOLVE and 2.9 in the CONQUER trial. The same trend we found in patients affected by chronic migraine, because In the Garlic study, we found a reduction by 11.5 days at month 3, compared to a reduction of 4.8 in the Regain and 6 in the Conquer trials. So very encouraging data in real life. So we have to acknowledge that we are comparing data from real life studies to data from randomized control studies. And this is not scientifically correct, but gives us an idea of what does it really happen in our patients compared to what the papers have told us in the randomized control trials. So what is really probably more meaningful is to express the proportion of patients who respond to a given treatment, because it's even more intuitive than the reduction in monthly migraine days. And here you see the proportion of 50% and 75% responders in the Garlic real-life study. On your left-hand side, you see the results in the episodic migraine patient, and on your right-hand side, the response in the chronic migraine patient. And the results are really very similar, because roughly 75–76% of both patients, episodic and migraine patient, show indeed a reduction by at least 50% of their monthly migraine days at the end of the third month. And as you see, approximately 32%, that means 1 out of 3, which is really a very huge proportion, is able to say, well, I have my migraine days reduced by at least 75%. So they are exciting and encouraging data coming from our real-life investigation. So we have once again to be reminded that it's not so scientifically precise, correct, to compare real-life data with data from randomized control studies, but it's it's interesting to also to stimulate your insights and to stimulate your discussion. You see the change in MIDA score in episodic migraine patient in the Garlic study with the red bar, and the magnitude of the reduction, 39.5, is really much bigger than the reduction shown by episodic migraine patient in both the EVOLVE studies and in the Conquer studies. This is a very interesting finding. But this is a finding that we have probably also to comment, because even though our chronic migraine patient did show a meaningful reduction in monthly migraine days, did show a very high proportion of patients showing a 50% or 75% response rate, actually the reduction in the global disability measured by MIDA score was not significant, as happened in the Regain and in the Conquer study.
Professor Barbanti, we have seen that the results in the MIDAS are quite different between the episodic population and the chronic population in the Garlic. Could you give us your explanation why we observe this difference?
Well, how to explain the fact that the reduction of MIDA score was not statistically significant in chronic migraine patients? Well, we know that the MIDAS score captures some features related to the way the patient lives in the house, with friends, work, and school. And what we know for sure is that the Garlic population is really a very representative population of patients affluent to a headache center with complex comorbidities, very often with affective disorders, anxiety, depression, fibromyalgia. And to me, the more reliable explanation is that probably 3 months is a time interval, is a too short time interval to manifest all the improvement in their lives, and so to definitely break the vicious cycle pain, depression, anxiety, stress, again pain. So I guess that a longer-term analysis of Garlit result at 6 months or later will probably show a significant reduction also in the MIDAS score.
Thank you very much for showing us the results with regard to the efficacy. Can you tell us something more about the tolerability in your study?
When a major point of galcanezumab is tolerability and safety, we can confirm this aspect in our real-life study because the patients showed minor side effects, which were very rare. As you see, less than 10% refer at least one adverse event in 1 month, 7% in at least 2 months, and only 2.4 referred an adverse event in at least 3 months of therapy. What do we know about the tolerability of galcanezumab using also data coming from post-marketing reports? We know that the most common events, which account for at most 10–11%, are local injection site reaction, pain on erythema, and so on, but very uncommon, even though we have to call them common by strictly speaking, are constipation, 1–1.5%, pruritus or cutaneous rash, or vertigo and dizziness, less than 1.5%. Uncommon urticaria, 0.3, 0.1, and anecdotal, extremely rare anaphylaxis and angioedema.
2020 was very much impacted by the pandemic. Have you evaluated if the lockdown had any influence on migraine patients?
We know that migraine attacks are the results of the interaction of our biology with the environment. And we know that stress is by large the most common trigger factor for migraine. That's why we wanted to analyze what was the response to galcanezumab and also erenumab in Italian patients during the lockdown, during the said 2020. So we consider 147 patients which were treated with erenumab or galcanezumab in 2 real-life studies called Garlit, as I've already mentioned several times, and early studies. And the aim of our study was to look for the consequences of the lockdown and probably the consequences of all the limitation to our freedom and also all the stressful events we were exposed to in terms of reduction in monthly migraine days, monthly analgesic intake, heat seeks, and so on. And what was really surprising is that despite these huge stressful impacts, all these events, negative events, we can witness a significant reduction in monthly migraine days also during the months of lockdown in this population, I repeat it once again, which was being treated with erenumab or galcanezumab.
Thank you very much for sharing with us the results in some of the outcomes in both the Garlit and the clinical trials. I wanted to ask you, are there any other outcomes that are really relevant for you when you assess the effectiveness of a treatment, and how are the results of galcanezumab on these outcomes in the clinical trials?
There are some other endpoints which have been addressed by post-hoc analysis. For example, the speed of action and the persistency of the effect of galcanezumab. As you see here on your left-hand side, we have seen that the differences in monthly migraine days in patients in the CONQUER studies treated with galcanezumab compared to placebo was already detectable at the first month. But what did it happen in terms of weeks? And this point is now explained in the graphic on your right-hand side, where you see that at the first week, after the first week of treatment, the number of weekly migraine days was significantly less in patients treated with galcanezumab compared to placebo. And this holds true also at week 2, 3, and 4. So a meaningful reduction in weekly migraine days in the CONQUER trial. So what about the persistency of the effect? What about the sustained effect? Here you see a very interesting sub-analysis in the EVOLVE trial and in the REGAIN trial. EVOLVE trial refers to episodic migraine patients, REGAIN to chronic migraine. And indeed, what I want to emphasize is the fact that we did not find only a meaningful reduction in monthly migraine days, but if you see in terms of weeks, the difference with placebo was maintained every week at the same level of significance. What does it mean? We did not find any end of dose effect. So the effect was sustained over weeks and over months, both in episodic migraine and in chronic migraine. But what about the quality of the attacks? Patients often refers that they improved not only in terms of migraine frequency, but also in terms of attack parameter, duration, severity, and so on. And this is a very interesting endpoint I want to share with you, is the total pain burden. What is the total pain burden? Total pain burden is the severity weighted duration. So is when you multiply migraine hours per migraine severity. Why is this endpoint, at least to me, needed? Because you see here this lady who has 6 migraine days per month. And she is not as disabled as this other woman who has 6 migraine days per month, but who has much longer migraine attacks and much severe, that is, she has a much higher total pain burden. So to sum up, the total pain burden tells us something more than the crude analysis of monthly migraine day. Now let's see this sub-analysis in a patient with episodic migraine in the EVOLVE 1 and 2 patient. And you see that the reduction in total pain burden was significant overall months 1 and 6 in this patient. And on the right-hand side, you see that this difference emerged at month 1 and was sustained over 6 months in patients with episodic migraine. The same applies to chronic migraine patients, because you see that the total pain burden was reduced when considering the overall period months 1 to 3, and also you see here that the reduction was detectable already at the month 1 and again sustained over months 2 and 3. So this means that the impact of the attack is reduced, and it has been calculated for both episodic migraine and chronic migraine, a reduction due to treatment with the galcanezumab of around 40 milligrams in terms of attack duration. So galcanezumab did not only provide a reduction in monthly migraine days, but in a shorter duration calculated in 40 minutes for each attack. So we are handling a molecule, galcanezumab, which provided data on migraine days reduction in migraine disability, very rapid speed of action, and sustained efficacy. How does this translate in daily life? So the improvement in presenteeism, in overall work impairment and activity impairment with galcanezumab versus placebo was significant for presenteeism, overall work, and activity impairment. Was not significant for absenteeism. There is something that we do not very often investigate, which is interictal disability. What does interictal disability mean? This interictal disability refers to all those symptoms, residual migraine symptoms, or not pain symptoms, for example, anxiety, avoidance, cephalalgia, which can definitely worsen the quality of life of the patient, and which accounts for the fact that really the patient, the life of the migraine patient is not fully lived as required. So it's interesting to analyze the reduction in the MIBS score. MIBS is a acronym indicating the scale to validate a scale to measure migraine interictal disability. And as you see, once again, in the Conquer migraine population, a statistically significant reduction in interictal disability at, already at month 1 and at month 2 and 3. And as you see, the statistical significance increases over time from month 1 to month 2 and 3. What can we say at the end of this analysis? That in episodic migraine patient, at month 3, 1 patient out of 3 had no longer interictal disability. And what about patient with chronic migraine? Well, in the patient with chronic migraine at following 3 months of treatment, we found a reduction by 30% approximately in those having a severe interictal burden. So very clinical, interesting data. Nice recommendation. Galcanezumab is recommended for patients suffering from episodic migraine with at least 4 migraine days per month, and in patients with chronic migraine who had failed at least 3 prior therapeutic treatments. And patient can prosecute the treatment when episodic if they demonstrate a reduction by at least 50% at month 3 in monthly migraine days, and by at least 30% of the migraine days if affected by chronic migraine. So galcanezumab, interesting, is the first monoclonal antibodies recommended by NICE for both episodic and chronic migraine. That's because galcanezumab provided not only data regarding the, let's say, usual efficacy endpoints, monthly headache days, disability, ictal-related disability, but also interictal disability. When a drug is effective, when a drug is safe, when a drug is well tolerated, usually has no problems in terms of treatment adherence. And this was precisely happened to galcanezumab as results from the RCT trials, because in episodic migraine, 80–88% of patients were adherent to the treatment up to 6 months, and 95% of patients when considering the trial performed in chronic migraine. The proportion of patients discontinuing due to treatment emergent adverse events which were related to the drug were less than 2.5%. Less than 0.5% the proportion of patients discontinuing galcanezumab treatment due to the problems, local problems of the injection, pain, erythema, and so on. And roughly 80% of patients referred to have had less adverse events that compared to the past, to the prior preventive treatment, the standard of care. So I want to address now this question. Do you think that total pain burden can be a more comprehensive measure of the efficacy of a preventive treatment than the reduction in monthly migraine days? What's your is impacting also So I want to share with you some other clinical aspects, because I think that we as clinicians have the privilege to identify some subtle clinical markers. I guess that clinical markers are obviously more easily obtainable, but maybe also sometimes more precise than biomarkers. Please, let's disentangle the migraine spectrum, analyzing more subtle aspects. For example, pain site. For example, the presence of allodynia. Do you know why? Because after all, CGRP is released in the periphery, so of the trigeminal nerve, and so those patients have unilateral pain. That means a pain which is tracing the distribution of the trigeminal nerve, could probably have more CGRP release at that level. But we know also that CGRP is released proximally into the trigeminal caudal nucleus, so it is also responsible, among the others, for the development of allodynia. And so probably also allodinic patient could better respond. Let's see, for example, the presence of dopaminergic symptoms. We know that 30–35% of migraine patients have vomiting and have yawning, which are symptoms related to dopaminergic activation. And again, please consider if the presence of psychiatric comorbidities or the basal monthly migraine days may be considered predictor of the response. And also, it's up to you, it's up to me, it's up to us. Consider if there is a level of prior therapeutic failures which identify the sort of cutoff which identifies those with poor chances of responding to galcanezumab. I am now approaching to the end of my presentation, and I want to show you this quite provocative slide, as you see, because it seems that all the trigeminal targeted treatments work in at most 60% of patients. Triptans, gepants, monoclonal antibodies, and so on. This is not a low proportion, because we know that this kind of proportion are indeed very high in pain treatment, in headache treatment. And I want to suggest you to parallel this proportion with that of patients with unilateral pain. Kellman calculated the frequency of migraine patients with unilateral pain in 66%. So it's a suggestion to see in our daily activity is, for example, patients with strictly unilateral or alternating unilateral pain do respond better to galcanezumab. So I want to conclude with some further suggestion. Some other homeworks we have to do. What about, for example, concomitant prophylaxis? Should we stop suddenly? Should we continue? When should we stop, for example? The second question is, even though galcanezumab did demonstrate a very rapid action, do we also have some patients who respond late? That is, are there late responders? Please, we have to identify them. How should, ideally, from ideal point of view, last treatment with galcanezumab? And how should we discontinue it? Because after all, we are not allowed to do a down titration. And lastly, how long should we wait following a treatment cycle with galcanezumab before starting a new one? I want to thank you for your attention with all these inputs, and I thank you once again. Arrivederci.
So I received a few questions on this talk, and I have answered the questions online for the speakers. One was regarding pregnancy, and as I say, there is no safety data about regarding monoclonal so far, so we are not using them, and we have to stop them like about 3 to 4 cycles. So that's about 3 to 4 months before pregnancy. And there is no also safety data about lactation, same. And many people, they ask about the price. I don't know the prices overseas. But the price in Kuwait is cost around $600 US, which is around 200 Kuwaiti dinar. One question is here, maybe last question. I'll see if I can see this from the screen. So let me just open this. So how long we use anti-CGRP? So that the European Headache Federation and the American Headache Association is actually recommend to use these drugs at least for 6 months. The evidence usually started after 3 months. So you don't give up on any monoclonal after, unless you just continue for 3 months, then it's really challenging. We don't know how much, but there is actually long-term data came from Eronamab, which is actually going for 5 years, and there is no safety issues. There are a couple of the side effects that can happen. Constipation has been seen more with Eronamab compared to galcanezumab, but otherwise these drugs, there are people who continue. What personally I do, at least I keep the patient on 9 months, then I'll see how severe is that time. So usually between 9 to 12, and then it's actually, we see how things will go. And as the speaker mentioned, is actually, can we keep another oral prophylactic therapy with these? This is something challenging, has been not looked at. So maybe more we will know with time about this drug. And the dose, I mentioned the dose is for Eronamab, you start with 70 milligram, and you may need to pump the dose to 140. For galcanezumab, you have to load with 240 in the first dose, then you just switch to 120 milligram for the subsequent doses. There is no evidence to keep 240. There is no, please, choice of after trying. Please, is it the first choice or after trying with other medication? All the recommendations actually should go after starting other oral medication therapy. That's the approval for the European Headache Federation and also for the American Headache Association. Is that's usually, and actually the American Headache Society actually recommended that people also fail botulinum toxin injection, and in order to fail, they have to fail 2 cycles. Well, it's a promising time in the era of migraine. There is this it says medication designated therapy regarding specific molecules. Whatever we had before was not actually designated treatment, but all these medications, these are a designated treatment for specific molecules that's released during the migraine attacks and comes low actually after this. This is most of the people who worked, Lars Evertson and Peter Gotsby, over the past at least 30 years actually came with these thoughts, and now we can see the reality since 2018. Well, I think I should stop now, and I'll hand it over to my colleague, Dr. Mohammed Ashkanani. Mohammed Ashkanani is a consultant neurologist. He's epileptologist by profession, and he is doctor from Ireland. He got his medical school, and then he did his neurology in Canada, and then he did as well his fellowship. He will moderate the next session. It's an excellent session, and we'll leave you with Dr. Mohammed Ashkanani.
Try now. Okay. Thank you, Dr. Jassim. Our next speaker is Dr. Maher Arabi, who is currently the director of the Comprehensive Epilepsy Program at Ibn Sina Hospital, and is also the vice president of the Kuwaiti League Against Epilepsy. Dr. Arabi did his neurology residency and epilepsy fellowship at AUB, American University of Beirut, under the mentorship of Professor Baidoun. Thereafter, Dr. Arabi joined Ibn Sina Hospital in August 2012, where he established the first epilepsy monitoring unit in Kuwait. Dr. Arabi has been a regular speaker in many epilepsy meetings across the region and has several peer-reviewed publications. The stage is yours, Dr. Arabi.
Thank you, Dr. Ashkinani. Thank you, Dr. Jassim, for inviting me for this great meeting. So today I'm gonna talk about the diagnosis of psychogenic non-epileptic seizures. This diagnosis has a lot in common with the diagnosis of epileptic seizures. So my slides are not moving. Okay, so I have no disclosure for this talk. What are psychogenic non-epileptic seizures? Are episodic disturbances of normal functioning with reduced self-control. They are usually associated with a wide range of motor, sensory, and mental manifestations. To differentiate them from epileptic seizures during the event, those patients will not have any epileptic activity in the brain. In clinical reality, the diagnosis of psychogenic non-epileptic seizure is a diagnosis of exclusion. So the outline of my presentation, I'll talk about the prevalence and burden, the profile of patients, the models of PNES, signs and symptoms, diagnosis, treatment follow-up, and the conclusion. So how common is PNES? If we look at the incidence in general population, it's 3 in 100,000. It's not common. It falls short after epileptic seizures and syncope. However, if we look at tertiary care neurology centers and the epilepsy monitoring unit, we'll see that it's about 18% of all cases referred. Now, I would like to talk about the incidence of such entity in the NOEL trial. And the NOEL trial is a large prospective trial about new onset epilepsy in Lebanon. It's multi-center. And 2 years ago, they looked at 1,880 consecutive patients. Those patients were referred for the diagnosis of epilepsy. And those are the demographic of the patients. And out of those patients, 442 patients turned out to have a diagnosis other than epilepsy. And about 21% of all of those patients were diagnosed as psychogenic non-epileptic seizure. Now, what was interesting in this data was that about 44% of those patients were already on anti-epileptic medications. Now, when they stratified those patients who had a diagnosis other than psychogenic non-epileptic seizures by age, and they looked at adults and children, and the cutoff was the age of 18 years, they found that syncope and non-epileptic psychogenic seizures were the most common diagnoses in adults. However, in children, there were other diagnoses like behavior, breath-holding spells, movement disorders, and parasomnias. Now, in this study by Salim bin Badis, published in Epilepsia, he looked at 251 patients that were admitted to the EEG monitoring, and he found that about 24% ended up with a diagnosis of psychogenic non-epileptic seizure. Now, what about the economic burden? In Europe, they did a study and they found that it costs about 21,000 euros annually to take care of such patients. Now, also, we have to know that there is a delay in diagnosis. And in this study by Marcus Ruber, he looked into 313 consecutive patients with psychogenic non-epileptic seizures. And it was found that about 7.2 years, there was a delay in the diagnosis. And when they looked at what factors were attributed to this delay, they found that younger age at onset, interictal epileptiform potentials on the EEG was one of the factors, and if they were already on anticonvulsive treatment at the time of referral. Also, other factors were factors related to the physicians themselves, because already if the patient was already diagnosed as epileptic seizure, it was difficult to change the diagnosis. Now, also another study by Ali Asadi Puya from Iran, he looked at the also factors that accounted for the delay in diagnosis in psychogenic non-epileptic seizures. And he found that the history of head trauma was associated with such delay. All other causes were statistically insignificant. Now, this is the photo of Charcot inducing a psychogenic non-epileptic seizure. And as great Babinski said about Charcot, to take away from neurology all the discoveries made by Charcot will be to render it unrecognizable. Also, this is a nice article that I recommend to read about the history of diagnosing of hysteria in women. What are the profile of patients with PNES? So most patients, when they looked at the history of psychological trauma and neglect in patients with PNES and other disorders like childhood emotional neglect and other diagnoses, they found that most of those patients had a history of psychological trauma and neglect. However, don't let this mislead you, as there are patients that don't report such history, and it's very common. Also, when they looked at the history of anxiety in such patients in this meta-analysis, they found that most of the patients with the PNES had a history of anxiety, and this was statistically significant, as we can see in this plot. When they looked at the history of depression, they found that most of the patients with PNES had the depression. However, in this meta-analysis, it wasn't statistically significant. And the history of PTSD was also common in patients with PNES. Now, one might argue that such patients had the depression or the anxiety after the onset of the psychogenic seizure, and that the anxiety and the depression was related to this disorder. So there was a data that was published in 2021 by the Noel group as well. And they looked at those patients who were newly diagnosed with PNES and compared them to epileptic seizures, also newly diagnosed, and normal controls. And they looked at the Beck depression inventory and the STI, the status and the state and the trait anxiety score. And they found that at the onset of the diagnosis, the patients with PNES had more depression as well as anxiety when compared to the epileptic seizures and the normal controls. So PNES is the tip of the iceberg. However, the persistent interictal state of arousal is the base of this iceberg. And this is a very nice study that was published in 2010 in Epilepsia that looked at the cortisol day curve in patients with PNES compared to the controls. And they found that in those patients, they had already a high level of cortisol at baseline. Also, when they stratified the PNES into those who had sexual trauma compared to those who did not, those who had sexual trauma had a higher cortisol baseline level. And they found that the high cortisol level positively correlated with the increased threat vigilance. So what is the PNES? What are the models? They found in patients with PNES, those who developed such a disorder were 6 times more likely to report having witnessed someone that had a seizure in front of them compared to those who had epilepsy. Also, there is something that we notice that across all cultures, the PNES is a little bit similar, and this raises the possibility of the conditioned reflex-like element of such disorder. So let me just spend a few minutes on this slide because it's a very important slide. It talks about the integrative cognitive model of patients with psychogenic non-epileptic seizures. So let's start down with the scaffold shaping factors. So there is a seizure scaffold that is present in such patients, and it is usually shaped by the hardwired behavioral tendencies, by the seizure models from self-experience, other, and media. Experience is misinterpreted as seizures. So sometimes a patient might have a syncope, and he may interpret it as a seizure, prior physical illness and injury, loss of consciousness, and traumatic experiences. So this scaffold will be activated by internal or external factors or cues. So the internal cue could be either a thought, you know, and the external cue could be a smell that they will correlate to a specific incidence or a thought or a condition. Then this will increase the threat perception, and they will anticipate a seizure onset. This will activate the seizure scaffold, and they already have a dysfunction of the inhibitory processing, and this is when they will develop the PNES. So it enables them to dissociate successfully from the adverse emotions. And that's why it's a conversion disorder. It's a dissociative disorder. Now, how to differentiate between PNES and epileptic seizures? Not everything that jerks and stiffens, like in this patient, is a fit. This we should keep in the back of our mind. Now, the first thing starts with the history taking. When we look at the history taking, at the profile of the patients with PNES, compared to patients with epilepsy, usually patients with PNES will resist giving the history, focusing not on the event itself, but on the surrounding consequences of the event. They will avoid giving details about the event. They will practically don't put any effort in formulation, and they have little description. This is compared to patients with epilepsy. So patients with epilepsy, if they had an aura, they will describe the aura very accurately, as well as when the spell happened, and then what happened after the spell when they regain consciousness. Now, is it possible to differentiate the psychogenic seizures from epileptic seizures based on the history taking, asking about the type of injury or tongue biting or other factors? Where in this study by Basil Abu Khalil and Peguero, they looked at the presence of injury in patients with epileptic versus psychogenic. And they found that it was present in psychogenic non-epileptic seizure, even though it was more common in epileptic, however, it was present. The only thing that they noticed was the absence of burns in patients with psychogenic compared to epileptic. However, as you can see here, the tongue biting, tongue bleeding, urinary incontinence, there was even status epilepticus in this cohort, or pseudostatus, better to call it. Those patients were intubated, and they had allergic reactions to the AED that were given. Now, those patients will have also like a type of aura, and this is the cue that we talked about, the sensory cue that they will that will trigger the psychogenic non-epileptic scaffold. And those symptoms could range from palpitations to sweating, trembling, all the autonomic symptoms. And this is very important to know, as when we ask about the symptoms and we induce the seizure, we will concentrate on such symptoms based on individual cases. Now, how reliable are the eyewitness in giving, specific details about the event, so that you can know from the history whether this is a psychogenic or epileptic seizure? And this was a nice study. They looked prospectively at eyewitness of seizures in the EMU versus those who witnessed psychogenic non-epileptic seizures. And they looked at 6 signs, 3 for the PNES, which are preserved awareness, eye flutter. And in the presence of the bystanders, if the spell will intensify or alleviate. While for the epileptic seizures, they looked at the abrupt onset, the eye opening, and the post-ictal confusion. And they found that the eyewitness report of these 6 signs were inaccurate in most of the cases and not satisfactorily different from guessing. So just relying on history is not enough to put this diagnosis. Now, what are the semiological features with differential diagnostic potentials? The signs that will favor PNES are a long duration of the event, fluctuating course. So there is like crescendo, decrescendo symptoms of the event. The movements are asynchronous. There is pelvic thrusting. However, as you can see here, this might also happen in frontal lobe epilepsy. Also side-to-side head movements, forced eye closure, ictal crying, and memory recall. While the signs favoring epileptic seizures are the occurrence from physiologic sleep, post-ictal confusion, and stertorous breathing. There are other signs that will not help in differentiating, and those include the opisthotonus, tongue biting. So tongue biting will not help us in differentiating between psychogenic or real seizures. Also, the urinary incontinence will not help, as it might happen in both. So let's look at this event. And we can see here that there is asynchronous movement, there is side head movements. Also, same patient having those high amplitude pelvic thrusting. Now, according to semiology, there are different semiological features. They classify them into 4 features, whether they are dystonic or posykinetic or pseudosyncope or hyperkinetic or axial dystonic. We'll not go further into such details. Now, also patients who report sexual abuse are more common to have a convulsive type of spells. They have emotional triggers, more prodromes, and flashbacks. So what is the gold standard method for diagnosis? It's the video EEG with induction. It's very important to induce one of the patient's spells and to capture it and to make sure that this was the spell that is habitual. So this was a patient who was 18-year-old. He had spells at the age of 5 years, started at school. And this was the semiology, difficulty breathing. And then as if a stone is on my chest, he feels the room is closing on him, followed by rapid breathing, loss of consciousness. According to him, he is stiff all over. He starts to have generalized shaking. During the spell, he can hear but cannot answer back. Over 1 hour, he would have clusters of several such spells. And he was already maintained on Keppra, on levetiracetam. And the MRI, to make things more interesting, had a right arachnoid cyst. So what we did is this EEG, and we did the induction. And I don't know if you can hear the voice from the video. Here I'm trying to suggest when the patient starts having the aura that the spell is going to happen. And we are asking him to do the hyperventilation with the photic stimulation. And shortly after, he will start having the spell, as you can see here. It's very easy to induce such events during the EEG. It doesn't have to be a 24-hour EEG. It might be a short-term EEG. However, you have to do this, and you have to give them 2 words to remember during the event, and then to ask them about it to know whether they had a preserved consciousness or not. So there is a lot that has been published about the provocative procedures. Let's say that before the year 2000, it was more, most of the physicians used to use the subcutaneous injection of placebo or saline. And then after the 2000, we are using more and more the suggestive method with the concomitant hyperventilation and photic stimulation. And in this study, it was also mentioned that if you talk to your patient just before doing the EEG and tell them that we will do an EEG, and during the EEG, we'll do the photic and the hyperventilation, and this most probably will induce a spell that is similar to your spell. This will make the success rate even higher. This is one of the earliest inductions, and it was done by hypnosis. So for the diagnosis of PNES, do we have to have both the EEG and the MRI normal? And we mean by EEG, it's the interictal EEG, not during the spell. So in this study of 329 consecutive patients, 206 of which had PNES alone, and 123 had both PNES and epilepsy. They found that in 48.5%, the EEG showed non-specific changes, and in 8.7%, they had epileptiform discharges. Most probably those were EEG trait. The MRI was abnormal in 27%, and the neuropsych testing was abnormal in 61%. And the cumulative abnormality in everything was 22.3%. So PNES is always a benign condition. As you can see here, that 27 venous cut downs were done to treat a pseudo status epilepticus. Also, repetitive pseudo seizures incorrectly managed as status epilepticus is common, and I'm sure lots of us already experienced such thing. Also, when they looked at the quality of life in patients with PNES compared to epilepsy, they found that the quality of life was even worse, as you can see here. And in a new study that was published, they found that the standardized mortality rate was 2.5 higher than the general population, and it was compared to those who had epileptic seizures. And most of the mortality was due to suicide. Now, biomarkers are not very good in diagnosing this condition. If you will do a biomarker, which is the prolactin or the CK, it should be done within 1 hour of the spell, and this is often difficult to do. Now, we have to know also that the PNES, it's a conversion disorder. It's not a malingering nor a factitious disorder. Communicating the diagnosis is very important. We have to avoid using such words as it's all in your head, you suffer from false seizures, and you should stop faking it. You suffer from a serious psychiatric problem, and you should see a psychiatrist urgently. On the contrary, when you communicate the diagnosis, it should be thorough, understandable, positive, non-judgmental, and compassionate manner. And in a study showed that most of those cases, 24 to 75%, will not follow up with a psychiatrist when you refer them if you don't follow up with them. Also, we have to know that the stigma that is related to PNES is a real condition that arises in response to real stressors, and these seizures are not consciously produced and are not the patient's fault. Now, the treatment, what's very important is the combination of SSRI with cognitive behavioral therapy. And in this study, it showed that this combination works good for such patients. However, in a recent study that was published, it showed that cognitive behavioral therapy did not add much. It was a prospective study, did not add much in the controlling the seizures or in anxiety or depression. It wasn't statistically significant compared to standardized medical care. However, it affected other aspects. I think also at PNES and driving, most of the time we encourage patients not to drive, as you know, it's a subconscious event. They might have it while driving, even though the literature, there are scarce cases about having, an accident during a PNES. So outcome, usually 50% continue to experience at follow-up, and at 10 years, they have high level of disability, as already said. So it's not a benign condition. So I will conclude here because my time has already over, evidently. PNES are highly prevalent, complex neuropsychiatric symptoms. The clinical presentation is stereotypic and can be objectively classified. Delay to diagnosis and treatment may result in significant psychosocial and physical morbidities to the affected patients. The burden is at least comparable to that of epilepsy and probably greater given the increased psychiatric comorbidities. And diagnosis and communicating the diagnosis to the patient, as well as making treatment recommendations, all of which work best with a multidisciplinary team. So it's a neuropsychosocial condition. That's why we should have this multidisciplinary team. Thank you.
It's okay. Thank you, Maher. That was an excellent talk about PNES. So then I will be giving the next talk. It's titled "To Treat or Not to Treat." Slide moving as well. Space. Okay. Okay. Which one is? Okay. Okay. Thank you. So welcome back, everyone. So the title is "To Treat or Not to Treat," basically talking about the management of first onset seizure and epilepsy. So a bit of outline of how the talk will go. First, a bit of introduction, then we'll talk about the factors to consider prior to considering therapy for first onset seizure. Then we'll talk about the risk factors for recurrence following first onset seizure. And then we'll talk about the effect of anti-epileptic therapy on the risk of recurrence of seizures following first onset. And then a bit about the American Academy of Neurology guidelines pertaining to this topic. So bismillah, a bit of introduction. So the discussion about treatment following first onset seizure should always include the following considerations. First, what is the chance of a second seizure? So if the chance of a second seizure is low, intuitively, you don't want to start the patient on anti-epileptic therapy necessarily, and vice versa. Second question you'll ask yourself following a patient presenting a first onset seizure is, what are the consequences of having another seizure? So if a patient is, for example, a truck driver or a taxi driver, the consequences of having another generalized tonic-clonic seizure for him are immense, as opposed to someone else who is bedridden and doesn't have much to do. The efficacy of treatment should also be considered in preventing subsequent seizures. So if we have very efficacious therapy, so it would be worthwhile trying most patients following first onset seizure. But if we have less effective therapy, it may not be worthwhile starting on treatment following first onset seizure. And then finally, what are the potential side effects of therapy? So if you have drugs that have a lot of potential side effects, you may not opt to start treatment following first onset seizure. And then we'll talk about what do you mean by first seizure. In general, first seizures are classified into provoked seizures and unprovoked seizures. Provoked seizures, as the definition implies, are seizures that are provoked by factors that are not necessarily related to epilepsy. For example, alcohol withdrawal seizures, hyponatremia-induced seizures, drug toxicity seizures, and so on and so forth. And then the unprovoked seizures can also be further classified into so-called acute symptomatic seizures, which are the seizures that the definition varies, but most people agree that are the seizures that happen acutely following a cerebral insult, such as a stroke or intracerebral hemorrhage or meningoencephalitis, within usually 7 days. These are lower risk for seizure recurrence compared to the following one, which is the remote symptomatic seizures, which is again the same thing. The patient has a cerebral insult, the same ones I mentioned, but they go on and to have a seizure, but months or years later after the cerebral insult. So not in the acute term. And these ones have a higher chance of seizure recurrence as opposed to the acute symptomatic seizures. And then we have seizures that are associated with epileptic syndromes, usually in pediatric populations such as juvenile myoclonic epilepsy or childhood absence epilepsy and other types of syndromes. And then we have the unidentified so-called cryptogenic seizures at the bottom. So What are the factors to consider following a first onset seizure? You see a patient in the ER, he's presenting with a first onset generalized tonic-clonic seizure. What factors should you consider before starting therapy, whether you're going to start or not? First thing is it a provoked or unprovoked seizure? That's the first question you should ask yourself. If a patient has alcohol withdrawal, which is a provoked seizure, if he is presenting 100 times with that seizure and 100 different occasions, you're not going to necessarily start him on anti-epileptic therapy if the treatment for that is withdrawing the provoking factor. So provoked seizures in general are generalized tonic-clonic seizure. So therefore, if you see someone who's presenting with a focal seizure, with few exceptions, or focal onset with secondary generalization tonic-clonic seizure, then you might think that this is probably an unprovoked seizure as opposed to a provoked seizure. Then the second thing you would consider prior to considering therapy for first onset seizure is the type of the seizure you're dealing with, and whether it's focal or generalized. As I said earlier, if it's focal, unlikely to be provoked, but sometimes focal seizures may not need therapy necessarily. For example, kids will present with first onset focal seizure in the context of Rolandic epilepsy. It's an epileptic diagnosis. However, it's known to be benign and less likely to occur. And if it occurs, it's unlikely to cause limitations in the patient's life. However, this depends on the patient, as some patients can have cortical dysplasia or other cerebral lesions that may require therapy, even after first onset seizure. Third thing I would look at is the patient's age, because incidence of new onset epilepsy is a bimodal distribution, as in many other diseases. And it tends to be most common in the children population, especially neonates, and prior to puberty, and also in the elderly. Elderly usually present with unprovoked seizures, and they don't have idiopathic seizures. So they're not genetic syndromes. They're secondary to cerebral lesions. Even if the imaging is negative, it's usually due to underlying cause. And the stroke is the most common cause of seizures in the elderly. Therefore, many of these so-called first unprovoked seizures in the elderly are in fact remote symptomatic seizures. So they're remote seizures in the context of a symptomatic cause, such as a previous stroke or cerebral insult. Moreover, in general, when an elderly patient presents with first onset seizure, it should be considered a focal seizure until proven otherwise, because it's unlikely for an elderly to present with first onset seizure for the first time as a generalized epilepsy syndrome. And I see this mistake been happening many times where people, elderly people presenting with first onset seizure, and it's probably a focal disconnect seizure, and people write a consult saying a patient with absence epilepsy. Absence doesn't usually happen in the elderly for a first time. Then you will consider whether it's an acute versus remote symptomatic seizure. As I stated earlier, acute symptomatic seizures are defined as the seizures that happen within 7 days of a cerebral insult within that time frame. And they're less likely to occur over the years compared to remote or delayed symptomatic seizure, according to many studies. According to this one study here, shows the risk of recurrence of acute symptomatic seizure following a previous cerebral insult, such as stroke, is only about 30%. Whereas if they've had a delayed onset seizure, so more than 7 days after the onset of stroke, usually months or years later, they're more likely to recur, more than 70% chance of recurrence with first onset seizure as a remote symptomatic seizure following stroke. Now, a bit of prognosis and trends. Most of you guys might know this. The risk of recurrence following first provoked seizure is very low. It's hardly 10% or less. And the risk of recurrence following a first unprovoked seizure is higher than obviously the provoked seizure risk. However, it's still quite low following first unprovoked seizure. It's less than 50% still. The greatest risk of seizure recurrence is in the first year. It's about 30%. It's a front-loaded risk. And then as you go on, the risk becomes slower, and it's about 50% by the 5th year, according to different studies. Several studies have shown, as I said, with long follow-up, that most seizures, if they occur within the first year or 2 years. This graph here highlights this fact. You can see here, do they see my cursor, by the way? Okay. So as you can see here, it's a front-loaded risk here, and on the x-axis, you see the different time in years. This is 1 year till more than 5 years. And then on the y-axis, you see here the percentage of risk of seizure recurrence over the years. And you can see there within the first year, most patients are likely to recur. If they're going to recur, they're going to recur within the first year. And then after that, the risk of recurrence increases by small margins only to reach about 50% by the time there's more than 5 years follow-up. So if they're going to recur, people with first onset seizure, they're going to recur in the first 2 years following that seizure. So what are the risk factors for recurrence? Well, there are many studies done on this matter. First study by Hauser in 1982. They looked at these risk factors and many risk factors indeed, and they found that these are the most consistent in their study. First is an abnormal EEG, and not any abnormal EEG. If there is generalized spike wave discharges, epilepsiform discharges on the EEG. Second, they found in their study positive family history of epilepsy in siblings. Now, this risk factors per se is not a consistent risk factor in different more recent studies. However, the third one is also important. The history of previous neurologic insults. So they've had previous stroke or cerebral insult of any kind. They are more likely to recur with seizures following first onset seizure. So remote symptomatic seizures is a risk factor for recurrence. These risk factors were associated with increased risk recurrence for more than 60%, according to the study. They also found that for patients with remote symptomatic seizure, if they presented with status epilepticus in this study, or Todd's paresis, who had previous history of acute symptomatic seizure, they had higher risk of seizure recurrence. So that doesn't mean that if you present with acute symptomatic seizure, you're more likely to have recurrence of seizure, but it means that if you're presenting with delayed onset seizure following a previous old cerebral insult, and then go on to have an acute symptomatic seizure, and if you had a history of acute symptomatic seizure before, then you're more likely to recur again. Acute symptomatic seizure has low risk of recurrence in this study, about 25%, as I mentioned, and treatment is not required for these people. What about seizure recurrence risk in children? Where children are more likely to have idiopathic or genetic seizures than adults as the first onset seizure, and they're more likely to be due to syndromes. Studies on children with first unprovoked seizure found that abnormal EEG, so again, that's another consistent risk factor for seizure recurrence, following first onset seizure, which is abnormal EEG. Usually that means epileptic activity, not just non-specific slowing. And then remote symptomatology is the second factor. So if they've had insult, or if they've had mental retardation or autism, or developmental delay. And then seizures during sleep, that's because of the connection with frontal lobe epilepsy in children. And history of febrile convulsions, usually complex febrile convulsions are more important. And if they are presenting with Todd's paresis implying focality, these were higher risk factors for seizure recurrence in some studies. Now, what is the effect of treatment on seizure recurrence? If you say, okay, is it worthwhile starting treatment on someone presenting with first onset seizure? Is it going to alter their long-term prognosis, prevent them from having epilepsy, or reduce the chance of seizure recurrence over the next few years? Well, let's have a look at this. Well, according to the first seizure trial, they found that in the untreated group, they only had 2 years follow-up, by the way, and in the untreated group following first onset seizure, the risk of seizure recurrence was about 50%. So people who went on to have a first onset seizure, they have a 50% chance of having another seizure in the subsequent 2 years. Whereas in the treatment arm, the risk of seizure recurrence was only 25% over the next 2 years. That means that there's about 50% risk reduction in people who receive treatment in the following 2 years. So there appears to be benefit, at least in 2 years' time. Therefore, they concluded that treatment does reduce the risk of seizure recurrence. Then let me ask basically everyone here. So why are we not using then treatment following first onset seizure in general? We're looking for these risk factors. If there is an absolute risk reduction, we can use it pretty much for anybody, right? But the problem is this. According to more recent studies, which had longer follow-up, more than 5 years, they found the same result or similar results in the first 2 years. However, immediate treatment did not, so that means immediately treating after first onset seizure as opposed to delaying treatment for subsequent seizures, did not influence the long-term prognosis or seizure remission rates. So more than 3 years later, they found that the onset of epilepsy or seizure recurrence is the same, whether you treat following first onset seizure or you delay your therapy until second or third seizure occurrence. So this timetable here shows you, it's from a meta-analysis showing different study groups with different patient populations. Showing you here the short-term therapy over 1 or 2 years. There's a big difference between the treated arm versus the untreated arm following first onset seizure. And you can see the percentages are half, and in some cases even less than 1/5 the recurrence risk of the treatment of the untreated group. So there appears to be a significant benefit if you treat them early on following a single seizure, as opposed if you don't treat them in the short term. The follow-up was only 1 or 2 years in these studies. However, if you extend your follow-up to more than 3 years at least, you start seeing that there is absolutely no difference, whether it's statistical or clinical, between the treatment group and the delayed or deferred treatment group following second or third seizures. So in this case, for example, they had almost exactly the same percentage of seizure recurrence more than 5 years later. So there is no benefit in the long term, whether you're going to start treatment following first seizure or you defer your treatment to subsequent seizures. Now, important point is this is in general for whether they have risk factors or not. Having risk factors for seizure recurrence make you more likely to benefit from therapy if you start treatment early on. And this is a question that many people would ask is whether if the first onset seizure that the patient presents with was a single seizure versus they presented with multiple seizures or even status epilepticus, is there a difference in outcome in terms of seizure recurrence later in the future? No. Okay, studies have shown that whether you're presenting with a first onset seizure as a single seizure or multiple seizures as the first onset seizure, there is no difference. Still, that's why the definition is still 1 seizure if it's within 24 hours. So now this is the summary American Academy of Neurology guideline. So they talk about the risk of recurrence is greatest in the first 2 years, as we saw. Therefore, there's an apparent benefit with immediate treatment of patients with first onset seizure, first unprovoked seizure, not provoked seizure, in the first 2 years. However, this apparent benefit pales in comparison to the effect that there is no benefit over the long term when there's follow-up more than 3 years, according to studies. And patients with prior, these are the epilepsy risk factors now, patients with prior cerebral insults or lesions, abnormal imaging, that's important, EEG with epileptiform discharges, and nocturnal onset seizures had the greatest risk of seizure recurrence. Studies have been consistent on these risk factors. The duration of first seizure and whether it was status epilepticus, as I mentioned, had no significant influence on future seizure recurrence risk. Now, these are the risk factors again, just for memorization's sake. Patients with prior brain lesion or insult, so remote symptomatology. Second is epileptiform abnormality on the EEG. Thirdly, significant brain imaging abnormality, whether it's CT or MRI. Obviously, MRI and TLE protocol with thin cuts to the temporal lobe is more desirable after a first onset seizure to rule out any epileptogenic lesions. And then nocturnal onset seizure to imply possible focal frontal seizures, which tend to cluster and recur. Now, you'll see here all the different risk factors that have been studied in different studies. And the ones in red are the only ones that have been consistently shown to increase the risk of recurrence by more than 2-folds. So what about the EEG? We talked about the EEG abnormality and increasing risk of recurrence, but by how much? What about if there was just slowing or non-specific changes? Well, according to this Dutch group, they did a 2-year study on the EEG abnormality and seizure recurrence risk following first onset seizure. They found that EEGs with epileptiform discharges following first onset seizure had more than 80% chance of seizure recurrence, as opposed to those with non-epileptiform abnormalities such as non-specific slowing, only about 40%. And it helps risk stratify to low risk those people who had normal EEG following first onset seizure. So if you have a normal EEG following first onset seizure, you have only about 10% chance of seizure recurrence, according to this study. Of course, the EEG is more sensitive, it's done within the first 24 hours, and the routine EEG detects epileptiform. This is the sensitivity of the EEG, is about 30%. And it becomes more sensitive, you do a more prolonged, sleep deprived with provoking maneuvers and stuff. What about imaging? CT is less sensitive than MRI. CT in general detects about 10% lesions following first onset seizure. With MRI detects up to 30%. And in one study, they found that CT only detected 12 out of 28 brain lesions detected by MRI. The things that CT misses usually are cortical dysplasias, low-grade gliomas, things that are subtle that the MRI only picks up, and mesotemporal sclerosis as well when it's subtle. So now balancing the odds, let's talk about in summary what's going on. When it comes to whether to treat or not to treat first onset seizure, certain factors have to be considered. First, you need to know if you are dealing with a provoked versus unprovoked seizure. If it's a provoked seizure, not an anti-epileptic issue. It's dealing with the underlying cause. If it's unprovoked seizure, then you need to know if there are associated risk factors that increase risk of recurrence for such patients. And you can tell that by doing some investigative such as EEG and MRI and clinical history and physical exam methods. Thirdly, once establishing that the patient has a high risk of seizure recurrence following first unprovoked seizure, you need to balance the potential side effect and the socioeconomic factors with the potential benefits of treatment that's given to the patient. Excuse me, to the patient. So you don't want to give necessarily a treatment to someone who doesn't have many risk factors and you might cause them renal failure or other. But on the other hand, if a patient has high risk of seizure recurrence, you may want to treat them because they're more likely to endanger their lives without treatment. So this is the slide before the last. This algorithm here shows you how to deal with a first onset seizure. First, you establish whether you're dealing with acute symptomatic seizure, correct the underlying abnormalities, or a provoked seizure. Then you just correct the underlying cause. If you're dealing with an unprovoked seizure, then you go on to do an MRI and EEG. If the MRI and EEG are abnormal, then you may want to start first line anti-epileptic therapy according to the patient you're dealing with. If the imaging and the investigative studies are all normal, then you may consider to defer the therapy following first onset seizure till more information becomes apparent. And EEG is not a one-off thing, it's a continuum. You need to do several EEGs if you're suspecting this patient has a higher chance of recurrence until you get, because it's a low sensitivity study, especially when it's done routinely. So in conclusion, the decision to treat or not to treat after first onset seizure is dependent on several factors, like we mentioned. Early treatment seems to reduce the risk of seizure recurrence in the short term, that is 2 years. However, it does not seem to alter long-term prognosis of epilepsy over longer follow-up following that, up to 5 years. Therefore, potential short-term benefits of treatment should be weighed carefully with the potential risk and side effects of medications in each patient and should be individualized as such according to their respective risk factors for recurrence. So at the end of the day, it's a case-based physician choice decision. Okay, thank you. So the next speaker is Dr. Abdullah Bargalaf. He is, again, غني عن التعريف. He did his neurology residency in Wayne State University, Michigan in the States. And then he did his epilepsy fellowship in Texas University in the US and electrophysiology there as well. And he's been working in Kuwait since after as a neurologist consultant and an epileptologist. Without further ado, I'll welcome Dr. Abdullah Bargalaf.
Thank you. Thank you. Okay. Hello, everyone. The title of my presentation, Anti-Epileptics, Drugs, What to Choose and When to Stop. Okay. So that's the outline of my talk. I'll have a brief introduction, then we'll have an approach to choose anti-seizure medication, Then that approach, I'll apply it to 6 cases. Then we'll answer the question of when to stop. Then we'll summarize and end the presentation. You can see this is a very busy slide, but the point of it is you could see the number of anti-seizure medication here. The next slide maybe put some timelines on it. We have plenty of them. So which one of these are we going to use? So you need to keep these questions in mind. I have what I call the holistic approach, like looking into this from more than one angle. I believe if you keep these questions that are written here in mind, you probably won't go wrong in choosing the appropriate anti-seizure medication. To start with, that's very important. You need to decide about the type of epilepsy and seizure. Is this a generalized seizure? Or generalized epilepsy or focal or both, because each one of them may have a different treatment plan or a different anti-seizure medication to be chosen. And then the second question I put here related to the first question. Do I need a broad spectrum anti-seizure medication or a narrow spectrum is good enough? The difference between broad spectrum and narrow spectrum is the broad spectrum anti-seizure medication, they work basically for both focal and generalized. Most of the narrow spectrum anti-seizure medication, they only work for focal seizure with one exception that I'll mention later. And then this third question I put here, what are the comorbid conditions? This is very important to keep in mind, and you'll see that in the illustrated cases that I have for you. And then again, another important question, is this a woman of a childbearing age? This is a very important question. Always keep that in mind. And then what are the side effect profile? What is the mechanism of action? This especially applies if you are gonna combine treatment. So it's a very important question. And again, what's the clearance of the drug? The clearance of the drug is very important when you are considering the comorbid condition, someone with hepatic problem, with renal problem. You need to know how the drug is metabolized and how is it cleared. And then is there any drug-drug interaction? Like if you are putting this anti-seizure medication, are you gonna have major drug interaction causing problem to the patients? Maybe an example of that, carbamazepine and some of the antibiotic, the microlides, erythromycin, and so on. And then do I need to combine anti-seizure medication? And then cost is also important, but it may not apply a lot here, especially in our health system in Kuwait. Now, as I said earlier, you need to decide, is this focal, generalized, unknown? This is based on the latest classification of seizures. This is the same, but it's a little bit expanded here. We could see, like for the generalized, they have the kind of subcategory, myoclonic, tonic-clonic. Similarly here for the focal onset and unknown onset. Next is putting all these together, you know, the classification of epilepsy rather than just the seizures. So it's the seizure types, then the epilepsy type, keeping the etiology in mind is also very important. Sometimes you need to direct your treatment to the etiology. For example, if you had an autoimmune condition, you probably need an immune modulating agent and all that. Here, I put a table. This is not inclusive of all the medication, but you could see here are some broad spectrum anti-seizure medication. As I told you, these work for both focal as well as generalized seizure. I think levetiracetam here, brivaracetam, although there are not kind of large-scale studies in generalized epilepsy, but I believe it works. That's why I did not put it here under the broad spectrum. I believe it does work. It has similar mechanism of action. So brivaracetam is not included here. Among the medication, like what to choose, lefenamide is an effective drug, but
but we don't use it as a first-line agent. The reason being the rare side effect of aplastic anemia and fulminant liver failure. These are very dangerous complications. So when I was saying earlier, like you need to keep in mind the side effect profile before you use the medication, this applies to this particular medication that we don't use very commonly. Similarly, vigabatrin, it can lead to blindness, but it's used in children who have infantile spasms. I was saying these medication work for focal epilepsy, narrow spectrum, with one exception. The exception is rifaxitamig is used for generalized absence, but it's very narrow spectrum. It doesn't work for the GTC. It doesn't work for anything else but the absence. So you need to think of these medication. What kind of medication do I need to use? Am I dealing with a focal epilepsy, generalized epilepsy, and then and which one of these kind of category you need to choose? I think it will be easier when I explain it to you with the cases. This is a very busy slide, but you could see if you have comorbid condition, the purpose of this slide, like your choice of medication and the medication to avoid, kind of will change based on the comorbid condition. For example, if you have someone with hepatic problem here, you won't use valproate or lamotrigine. So on someone who has a lung disease, you would not use the benzos. And this goes on and on. You could see here the medication here to be avoided. Most of these medications, if not all these medications are very strong enzymes inducers. For this reason, they have a strong drug-drug interactions, and they get avoided. For example, here in hypothyroidism, osteoporosis, and so on. So again, the point of this busy slide was to keep the comorbid condition in your mind and kind of choose the best drug that works for these patients. Now, when we ask the question, is this a woman of childbearing age? I got this slide from the North American Anti-Epileptic Drug Pregnancy Registry. You could see here lamotrigine and levetiracetam, large number of patients, and the risk of malformation, if you see here like 1.9, 1.8 for both of these medications, and when you come to the internal control is like 0.9, the external control is similar kind of to the general population, like 1.7. So these are really the drug of choice for a woman with childbearing age. And again, from this slide, you need to avoid valproate. You really need to avoid valproate. Lacosamide is new. There isn't a lot of patients that have been on it, but, and again, you could see the confidence interval is large here, but it's something to kind of watch for. And then the rest of the medication, as you could see, phenobarb is maybe a little bit kind of similar to valproate. So from this slide, lamotrigine and levetiracetam are the best. Now let's start with these cases. Let me play the video. So when I play any one of these videos, I want you to decide what kind of seizure is this and think what anti-seizure medication we are going to use here.
Fresh linens, ask your nurse. Another thing you can count on, assuming your condition and treatment allow, are 3 square meals a day. Breakfast is served from 7:30 to 9 in the morning. Lunch is 11:30 to 1.
I'm going to give you a code word. I want you to remember bridge for me. Can you point up to the ceiling? Can you tell me where we are? What's the name of this place? Okay, you're all right.
Oh my God, please help me, God. Please help me, God.
Show me 2 fingers.
I love you and trust you, Jesus. Please help me.
Okay, show me 2 fingers.
Oh my God, help me, God.
Where are we? It's okay.
Where are we? Okay, God, please take us away from Jesus, please. Oh my God, take it away from God, please. Oh my God.
Tell me your name. What's your name? Good, good. Where? You're okay. What month is it? What month is it? What month is it?
Oh my God.
You're okay, Bill. You're okay. What's 2 plus 2?
4.
Good. What time's it on that clock?
10 after 1.
AM or PM?
PM.
Great. Great. Spell hand for me.
HANDS.
Good. With your left hand, touch your right ear. Awesome. Good job.
Housekeeping staff will come in between the hours of 8
Okay,
a.m.
so
If you are out of your
so with this is a clearly focal seizure. So do we need a broad spectrum anti-seizure medication? The answer is no. So, but keep the comorbid conditions here in mind. This man has ischemic heart disease. He has dyslipidemia, diabetes. Are we going to use something like carbamazepine? It works. I mean, most of the comparative studies that are done against carbamazepine because it's a very effective drug. But I don't think it's a good choice here. Reason being, it's a very strong enzyme inducer. It will mess up his dyslipidemia. And even if he has medication for his ischemic heart disease, if he has beta blocker, calcium channel blocker, you will probably reduce the effect of these medications. So I don't think this medication, although it's an effective medication, I don't think it might be my number one choice here. So we would want to choose a medication that does not kind of have this drug-drug interaction and reduce the efficacy of the other medication that the patient is using. I think levetiracetam is a reasonable choice here. I know it's a broad spectrum anti-seizure medication, but I think it's a very appropriate one to use here. And we know when I was talking about the side effect profile, in the adult population, maybe up to 30% of some people kind of get anxious or depression or get angry. So if we face this problem, I think oxcarbazepine or L-carbazepine could be kind of a substitution, a good substitution. Although they may also induce the liver enzyme, but not as bad as carbamazepine. Also, glucosamide might be an appropriate choice here. Again, looking to the side effect profile, some of the doctor might be afraid of the bradyarrhythmias that it might cause, but not all ischemic heart disease patient will end up having bradyarrhythmias from the use of glucosamide. So to summarize with this case, you'd want to avoid a medication that has a strong enzyme inducing, liver enzyme inducing features, the like of carbamazepine, phenytoin, and so on. And then one of the, I think the best choices here will be levetiracetam, glucosamide, and trileptal or oxcarbazepine. And one of these will work. Let's see the second case here.
Whoa, girl. Okay, I want you to remember the word dynamite. Watch out for your glasses there. Show me 3 fingers. Okay. Clap your hands 2 times. How old are you? How old are you? Show me 4 fingers. Can you do that? That's it. Okay. How do you say your last name? What's your last name? Hi. Okay. Can you count to 10 for me? Count to 10. You're drooling a little bit. You look a little grayish, but you're doing okay. Okay. Can you clap your hands 2 times? What is this on my nose? Code word is dynamite. You're doing good, Miss Abrams. Thank you. You're okay, hon. Relax.
Okay, so as you could see, this is also a focal seizure. So do we need a broad spectrum anti-seizure medication? The answer is no. But look at the comorbid condition here. We have a woman with end-stage kidney disease. So
what are we going to choose? So probably we want to choose a medication that kind of doesn't rely on the kidneys for excretion, and she's on end-stage kidney disease and on dialysis. And a medication that does not get dialyzed easily, and you run into the problem when around dialysis that the patient may have seizures. So what are the choices? One might think of valproate. I do have a problem with valproate. Its metabolism in the liver, it may not get affected by the end-stage kidney disease, or because it's highly protein bound, it does not get affected by dialysis a lot. But the problem we face here is this patient age. Old people, or like around this age, starting them on valproate, they may have cognitive problems, sleepiness. So although the way that valproate works might sound kind of attractive to use it, but it would not be my first choice. Now, having said that, although levetiracetam kind of get excreted, renal excreted, and it does not have much to do with the liver, but adjusting the dose for end-stage kidney disease might work, and given supplemental doses like mid-dialysis or close to the end of dialysis may fix this issue with this, that it gets dialyzed, or the accumulation problem. So given small doses like 250 per day or 500. Also, berivracetam, interesting drug. To be honest, it gets metabolized in the liver into ineffective kind of metabolite. In people with end-stage kidney disease, there is 10-fold kind of accumulation of these inactive metabolite, but they do not cause any safety issues. So with berivracetam, in fact, you don't need to change the dosing, and you may use it effectively in these patient population. So these two kind of are maybe good choices. A third choice, phenytoin, I think, is a good drug here. Maybe better tolerated than valproate, better tolerated than valproate. So let me move on to the next.
Get these kids in before school starts. Get things started before school starts. That's the best thing. Blue.
So for the sake of time.
Green. Yellow.
This is an absence seizure. I won't kind of play the whole video. The study shows that valproate is a very effective treatment if they have GTCs. If they don't have GTCs, ethosuximide is a very effective treatment. This is a self-limiting kind of epilepsy syndrome. Look at this patient eye moving to the right.
Did you make a good deal? Of course. Well, we're about to find out. Had you said no deal, your next case choice would have been...
Again, for the sake of the time, this patient loses her awareness, and clearly you could see her eyes looking to the right. She has focal seizures, and she's young. She's planning pregnancy. So if you remember the previous principles that we were saying, the best two medications, safe medication are lamotrigine and levetiracetam. So if the seizure frequency is not high, I think it is safe to start with lamotrigine. However, if the seizure frequency is high, you could use a bridge. You could use like lamotrigine and use a bridge, be it like you could use the benzos, the fact that she has untreated anxiety, kind of calm her anxiety, or you can even bite the bullet and use levetiracetam, but be prepared that this patient may get worse in terms of her anxiety. Let's move on to the next case. So you have seen the myoclonic jerks, and then he goes on into tonic-clonic seizures. Let's suppose that this is a juvenile myoclonic epilepsy. What would be the best treatment here? The studies have shown that valproate is a very effective treatment for these patients. Another, levetiracetam is another one. I believe racetam will work, but it has not been extensively studied. The benzos, clonazepam is a very effective treatment here. And again, for the myoclonus in resistant cases, we might elect to choose zanosamide. Zanosamide is also a good one. When we talk about myoclone, especially in progressive myoclonic epilepsy, perampanel. The problem with perampanel is the psychiatric side effect is really high. So these would be my choices for this particular syndrome or myoclonia. I believe this might be the last case I have.
Can you make a fist with your right hand? Make a fist with your right hand. Head turning to the left. Can you get 2 milligrams of atropine?
So again, for the sake of time, the point here, this patient has focal epilepsy, but she have a major problem in her liver. So the medication that one would want to use that doesn't have extensive liver metabolism, and levetiracetam is a good choice here. A couple of medication, they have absolutely nothing to do with the liver. They're purely excreted in the kidney. One is pregabalin and the other is gabapentin. The problem with those two medications, when compared to Lamictal in previous study, they were slightly less effective, but they do work. They do work sometimes. In fact, I do have patients that on these medication, and especially if they have comorbid condition as pain, they do work. So levetiracetam, pregabalin, and gabapentin. But keep in mind, they might be less effective compared to other anti-seizure medications. So a few more slides. If you have combination treatment, give a good dose and then add medication with different mechanism of actions. For example, don't use lacosamide with, carbamazepine and phenytoin. All of them work on the sodium channels. Like you just use a medication with a different mechanism of action. If you start a new agent, just titrate that slowly and carefully. Now, try different dual therapies. There is an evidence like combining those two treatments, valproate and lamotrigine, they have a synergistic effect and are very powerful combination. But you need to have good experience because to kind of use those two combinations, especially like starting lamotrigine, if someone is already on valproate, might be dangerous and lead to Stevens-Johnson syndrome. Okay, when to stop? I have a couple more slides and then we'll summarize and wrap up. Keep these points in mind. If you want to stop anti-seizure medication, stopping the anti-seizure medication increases the risk close to 3 times compared for continuing treatment. So it's not without risk. And most of the studies, if not all, it was mostly related to focal seizure, not generalized epilepsy. And so most of the generalized idiopathic epilepsies, they don't remit, especially juvenile myoclonic epilepsies. I would not stop the treatment for these patients. Even like I have some patients that are well controlled for 7 years and small doses of medications, but we know that the relapse rate in these patients is like 90%. So I would not do it. Then late withdrawal versus early withdrawal. And the time period that define late and or early is 2 years, like 2 years early, 4 years late. So in one particular study, the late withdrawal Like if they remain seizure free for longer, like close to 4 years, then the risk of relapse at that particular study was 34% in comparison to the 46% that was done around 2 years. If you have an abnormal EEG, your relative risk of having a seizure is 1.5 times greater. And then the age of onset, if it was, before the 2 years old or after 10 years old. So the ones with the before 2 years old, they have these genetic and resistant epilepsy. It's less likely, that they will have remission from epilepsy and seizure. And, this in between age group, these are mostly related to the self-limiting, epilepsies like of absence seizures. If you have history of status epilepticus, intellectual disability, and very frequent seizure, it is more riskier. So if you want to stop, if this is a self-limiting epilepsy like absence, if they have single type of seizures, seizure-free for 2 years, normal EEG, no brain structural abnormalities, and normal neurological exam. So to summarize, this is my last slide. We were trying to choose which anti-seizure medication to choose from. We kept so many points in mind, deciding whether we have a focal epilepsy, generalized epilepsy. We kept in mind the side effect profile of the medication, the mechanism of actions, and if we wanted to combine treatment together. And then I gave example 6 cases, like how did we apply these principles, and then when to stop the anti-seizure medication. Thank you very much. And the videos, I got it from this atlas. Thanks.
Hello. Hello. Because no.
Dr. Mohammed, I have few questions. I got them on me, and then you can direct them to the speaker. So one of the question is, many patients with juvenile myoclonic epilepsy, they are on Dibecane and they go into pregnancy. So what can you do for such patients?
Okay. So for juvenile myoclonic epilepsy, we know also levetiracetam is a very powerful medication. It can be substituted, but not close to the pregnancy time. This needs to be kind of planned way in advance. Also, the benzos, the clonazepam, are less riskier. Like if you want to combine treatment, the data about lamotrigine, sometimes it can worsen myoclonic epilepsy, but sometimes it works. So we have kind of 3 agents. 2 of them are safe for a juvenile myoclonic epilepsy, and it needs to be planned way ahead of time. However, if the woman got pregnant on this particular medication, obviously before she gets pregnant, folic acid, she needs to get folic acid. It does reduce the risk of major congenital malformation. Being on Depakine, it's not like guaranteed 100% you will the kid will have major congenital malformation. The risk is high, especially with the dose of 50, like more than 1,500 milligrams per day. The higher the dose, the higher the chance. And not just that, we have the cognitive impairment that the kids, like when they did follow-up studies, like years after the kid were born, they do have cognitive impairment and autism and so on and so forth. So we need to avoid that at all costs. However, if she gets pregnant, maybe she'll not end up having the problem, So just, you don't switch it, like don't make the switch during pregnancy, because that may have even major consequences. If she has a seizure, or she get, if she end up with tonic-clonic seizure, like myoclonic tonic-clonic, she may lose the fetus. So don't do the switch during pregnancy. Thank you.
There's another question. Is there any ICOMBA? Another question? ICOMBA, and pregnancy?
Well, there are no data about Fycompa and pregnancy, so I would not comment on that. I don't know the answers. I don't know if Dr. Maher.
Any of the speakers?
There is no data. I agree. There is no data.
Yeah.
One last question also I got. So if the patient stopped the anti-epileptic drug and they had a seizure, and then the patient went to stable for 2-3 years again, will you try to stop again? EEG is normal, MRI is normal.
You know, it's just, maybe I'll defer this to Dr. Maher.
Yeah. Actually, if the EEG and the MRI are normal, I usually tend to wait more. Like I don't wait 2 years again. There is no solid data on that. However, I usually like wait for 5 years and then try to stop it. There are some, there are some that you might stop it and they will not have any seizure recurrence. But I will not wait for sure for 2 years and then try to stop it. I will tell them that I'll wait longer and then we'll see. But very important thing is to repeat the sleep deprived EEG. And what's also very important is during what I do is that during when I decrease the dose of the medication, I also repeat the EEG. And if there are any interictal discharges that correlate with the epilepsy syndrome, then I will tell them, the risk will be high for a seizure recurrence. Then we have to go back to the initial dose. Yeah, but I will not wait 2 years. I will wait like for 5 years and then try.
Well, thank you, Dr. Maher and Dr. Abdulrada. Our next session now is Satellite Symposium by Novartis, titled Reimagining MS, or Reimagining MS, sorry.
يقول لك في أسئلة محمد.
I think I have an issue with the hearing. The speakers, I think there is a problem. I don't know where's the issue. Hello? I was hearing you and suddenly nothing happened. It stopped now. I cannot hear anything. There is a problem, I think, with the speaker. With the speaker.
We can hear you clearly.
Yeah, but I cannot hear anything.
Stop it on the right and left hand.
Hello? So there are few epilepsy questions.
Yeah, I saw it. Select the microphone.
Dr. Mohammed Ashkenani is
yes.
typing the answers for these questions. So Dr. Mohammed Ashkenani
Yes,
is going to
same assistant.
with the speakers for the epilepsy session for the few questions that we couldn't do it.
Sorry?
While we are waiting now for Dr.
There is only Mac Pro speaker.
Put it to
Pro speakers, but
get the last
hearing
thing in today sessions, the Satellite Symposium by Novartis.
Good afternoon, everyone. Sorry for this glitch. We had some logistic issues. I need to share my presentation. So, all right. So first of all, thank you for the Kuwait Neurology Conference organizers and the scientific committee. And also we thank Novartis for inviting me to present their symposium today. I'm going to talk mainly about some updates in the DMTs, but also I'm going to talk about why it is important to intervene early in MS. This is the agenda. I'm going to talk about some role of B cells in MS and also the difference between anti-CD20s. So first of all, we will agree that the damage that happens in MS starts very early in the disease, even sometimes at the RIS or CIS stages. So we need to preserve as much as we can earlier on. Also, there are lots of lesions happening in the MRI that probably we feel they are asymptomatic, but at the end, when they accumulate, they will affect the patient quality of life and well-being on the long term. According to the evidence that comes from multiple earlier studies and trials, early intervention, especially in those with highly active disease, probably gonna delay the progressive course because probably early inflammatory changes may lead to an increase in neurodegeneration with the long term. And we know that the inflammation of active lesion driven mainly by peripheral T and B cells. Most of the drugs do not go into the CNS. So we are mostly targeting the peripheral T and B cells, and that's our effective anti-inflammatory mechanism to prevent damage to CNS. Now, as MS progresses, there will be a central inflammation and neurodegeneration. And the issue with this is probably how we can target those. So probably we need to prevent central inflammation. And once it happens, then we have to think about a mechanism where a drug can enter the CNS in order to shut down the inflammatory process. So with this, once you have accumulation of disability, probably there's not much you're going to do. So you probably need to prevent it very early to preserve the brain function. And according to many studies, as you know, one of the milestones in MS patient is time to EDSS-3 or DSS disability scale of 6, where the patient is actually using a cane. So patient who had one relapse probably gonna go into EDSS within 22 years. However, if they have 2 relapses in first 2 years or 3 relapses or more on the first 2 years, you are pushing this very fast. So a patient may actually go to EDSS, i.e. having a cane in less than 15 years. So our target is very important early on the disease, and that's why we tell patients the first 2 years after diagnosis is a key for a long-term disability and also well-being. And this also appears with the MRI lesion load. If you have a small or a very low lesion load from the beginning, especially in the first 2 years, you're probably going to take more time to achieve the secondary progressive course or EDSS-6. However, if you have too many lesions, 3 or above, and sometimes we keep 7 or above, then we are talking about very highly active disease. You probably need to shut down this inflammatory lesion. Moreover, cortical lesions now appear more associated with an increased risk of secondary progressive course. And we all know all the trials of the CIS, where most CIS trials, if in the placebo arm, if you delay treatment for 2 years, they're not going to achieve the same response when it started early on. So time to EDSS, whether it's 4 or 6, is actually very important. If you start a treatment within the first year, you're going to reduce the risk of progression by around 7% per year to reach the EDSS-4. So once you delay it for 3 years, 4 years, you're talking about 15% or less of going into SPMS. So our key message is start early to delay the conversion to a progressive course. And this was seen also with the long-term trials. those with interferons or glutamate acetate. Those who start late actually cannot join the trend of the delay of SPMS in those who are on treatment. So the benefits associated with later treatment waned over time and disappeared by 8 years. So you probably need to go very fast earlier on. Now, high efficacy treatments been coming to the market since 2008. And historically, we always talk about escalations, and we go to a first line medication and second line medication. However, these kind of principles are not working for those patients with highly active disease or very aggressive patients. So now we are always talking about highly active therapies earlier on to initiate it in a patient who has the characteristics of highly active disease or aggressive disease. And this indeed will lower the risk of conversion to SPMS compared to those who go on start low or go slow. So this principle, the old schools are probably changing, and that's why we are going very aggressive in terms of treatment with MS patients. And one of the MS-based studies actually tried to assess the treatment with high efficacy medication compared to low efficacy medication. And in this trial, when they started patient with fingolimod, alemtuzumab, or natalizumab, they found a significant reduction in achieving the risk of conversion to SPMS when compared to first-line treatment. So even in those settings, we know high efficacy medication probably will reduce the risk no matter how. However, the risk is reduced more in those with highly active disease. So talking about mechanism of the pathogenesis of MS, we always talk about T cells. However, the B cells role has come into our insight in the last 10 years. And we all know that B cells are present in the periphery and also present in the CNS. And most of our targets usually is in the periphery, whether it's a bone marrow, lymph node, or a spleen, because it's not easy to actually target or enter the blood-brain barrier unless there is a significant inflammation where the blood-brain barrier may be open. And inside the CNS, the B cells are probably not easy to attract, and that's why it's not easy to eliminate all inflammatory cells in the CNS. So the target is actually mainly in the peripheral, because we think the pathogenesis of MS is actually inside to outside, or what we call from periphery to CNS. And we all know the function of B cells. I'm not going to talk about the pathophysiology of B cells. They present as an antigen, and they act as an antigen presenting cells, and they produce antibodies, cytokines, and also play a big role in the ectopic lymphoid structures. And there is some evidence in MS population where the B cell actually ruled in the pathogenesis. Most clearly, I think, is the oligoclonal band we find in the CSF of MS patient. This is an evidence of a B cell pathology. Also, when you use B cell depleting therapy like rituximab or ocrelizumab, we know that they are very effective. So we know the B cell rules actually there in MS patients. Now, when we talk about anti-CD20s, there are 3 types in the market. There are actually more, but this is mostly, to MS, related to MS. We all know the rituximab, which is the chimeric form, and the humanized ocrelizumab, and the new drug ofatumumab, the fully humanized product. Now, the difference between rituximab and ocrelizumab and ofatumumab is actually the binding sites. Ofatumumab binds to 2 distinct non-continuous epitope, which actually give rise to low off rate and also deliver potent and sustained effector activity. And ofatumumab is actually being tested in mice by 2 doses, the intravenous and the subcutaneous. And it was found that the subcutaneous administration goes directly to the lymph nodes, and also spare the spleen. And this might be very important also for the depletion of B cells, because we are preserving the other organ B cells, which has some of the memory B cells. So more effective towards the lymph nodes when we talk about ofatumumab. And this cartoon shows you how B cells are rapidly depleted and repleted after you stop the subcutaneous ofatumumab in the lymph node. So that's one key mechanism of action of ofatumumab. And once you stop it or give the washout period, rapidly you will see the B cells are repleted. So this is a big difference when you compare it to other potent B cell depleting therapy, where it may take up to 6 months to have the cells repleted in the periphery. Finally, I'm going to talk about, I think this is the main clinical trial, Asclepios. It has 2 phase 3 trials, which led to the approval of ofatumumab for relapsing remitting MS. This is the study design. It is a placebo control, but in a way where there is a comparator arm. So the comparator arm is teriflunomide, and also the teriflunomide will receive the placebo ofatumumab, and the ofatumumab will receive the placebo teriflunomide. So it is a double-blind, double dummy with active comparator in a controlled parallel group. And it was a multi-center with a flexible design, because they have the primary outcome was time to the relapse. And so it was a maximum duration of up to 30 months in each arm. The comparator arm is teriflunomide 14 milligram once daily, plus the placebo subcutaneous, which is the placebo for ofatumumab. And ofatumumab was 20 milligram sub-Q, which was injected every 4 weeks after a loading doses for the first month with the 3 doses, plus the placebo oral. So if you look at the population here, we're talking about mainly relapsing remitting, age less than 15 with the EDSS up to 5.5. So we are picking some of the transitional patient with EDSS 4.55, but primarily you will see some of the progressive patient probably entering the study design based on the EDSS cutoff if they don't have a strict diagnosis of SPMS. And then there is the open label follow-up study for up to 5 years after the end of the actual phase 3 trial. This is the demographic and the baseline characteristics. And you can see both Asclepios 1 and 2. There is no big difference between the treatment arm and the comparator arm, which is teriflunomide. If you look at the EDSS score, almost similar. If you look at the GAD-enhancing lesions in both arms, almost similar. So there is no big difference. And also if you look at the age, so a little bit older than our population in the Middle East, where we have the mean age is around 27 to 30. But again, for the sake of the trial, both are the same into the arms. And this is the main outcome, and this is the primary outcome measure, which is the annualized relapse rate. And you can see there is a significant reduction in ofatumumab arm compared to teriflunomide. So bear in mind, this is not compared to placebo. This is compared to a first-line treatment. And as you know, most of the trials nowadays, in the last 2 or 3 years, there is always a comparator arm. And in Asclepios 2, there is a almost 59% relative risk reduction of annualized relapse rate. So both trials were positive. So just to convert this number to a clinical number, we can tell patient, yes, there is a a relapse in every 10 patient years. So maybe in 10 years of this patient, you may get a relapse. This is how the numbers are interpreted. And if you look at the secondary outcome measures, and the first one was the guard-enhancing lesions, and you can see almost suppression of inflammation of the MRI in both trials, probably better in the slow-plus one. This is used, I mean, almost near completion of suppression, and this is seen across all the B-cell depleting therapy. And this is the number of new or enlarging lesions, again, similar to other studies. We are always talking about 80s. And I think this is one important outcome measure, which is the confirmed disability worsening at 3 months and 6 months. And again, the risk reduction between 32 to 34% over 6 months. So this is a very important message, is there is also a reduction in the disability progression over time, in the sustained, what we call, because 6 months is a probably sustained confirmed disability worsening. And as all other studies, we always do the post hoc analysis to assess the no evidence of disease activity, NEDA. And again, in ofatumumab arm in the first year is around 47% compared to 25% in the teriflunomide arm. And if you redo the analysis for the second year, this goes to 88%. And the NEDA is defined as no relapses, no MRI lesions, and no progression within the 6 months. So almost up to 9 out of 10 patients taking ofatumumab achieved NEDA in year 2. So just bear in mind, there is what we call reassessment of the NEDA in this trial after year 1. So rebasing after year 1. Safety, there is no any red flag so far. As expected, a slightly increase in injection reaction. I mean, this is a sub-Q drug with just minimal compared to the placebo arm of the sub-Q, but there is no other red flags in the actual adverse events, and there was no deaths or any serious adverse events that led to hospitalization or discontinuation. Now, for those who reported some injection site reaction, majority of them were mild and usually disappear by the 4th or 5th injection. And when we talk about mild, we are talking about grade 1 or grade 2, where it is only redness or itchiness or tenderness. But majority of those will actually resolve with time. So this is my end of the presentation, and I think we have 5 minutes for the questions. Thank you.
Oh, thank you very much, Dr. Ra'ed.
I think I have an issue with the speakers here. I cannot hear.
Thank you very much, Dr. Ra'ed, for this great presentation. Do you hear the voice?
I cannot hear
Do
anything.
you hear my
I
voice,
think
Dr.
the IT
Ra'ed?
need
Or
to do something with this.
no? Do you hear my voice? My voice. Do you hear my voice? I think, Ra'ed, you are not hearing me.
Dr. Jassim, we can hear you very well.
Sure. I'm not sure if Dr. Ra'ed is hearing me, but anyhow, really, thank you so much for being an excellent audience. We have like more than around 500 people attendees. The registration for this conference is more than 1,500 people. And throughout the day, we have been having 400 to 500 attendees from all over the world. And that is really an excellent for a virtual event. We assume that some people, they drop, and the other people, they come around, and I'm very thankful. Again, just to tell you that today we went through headache, and we discussed trigeminal autonomic cephalalgia, and we discussed the update in the management of migraine, and we discussed also the idiopathic intracranial hypertension. And then we had a stroke sessions, and Dr. Adari spoke updating the treatment of a stroke, and what are the new treatment, and the extended window for the TPA, and also if you can combine and tenecteplase and also ticagrelor, and also you have to lower the LDL for the patient with a stroke. And she gave an excellent presentation also about anticoagulation, and she spoke about the window about 4 to 14 days after these things. If there is no issue with the CT, then you can stop. Then you can start the anticoagulation again. Now, also there is after that, Dr. also Osama Al-Bakr, he gave a presentation on cerebral venous thrombosis. Something you have to know about a new oral anticoagulation in cerebral venous thrombosis, that there is a paper on JAMA, and this paper mentioned that non-inferiority for direct oral anticoagulation for these agents, and that's probably a good options for people with sagittal sinus thrombosis, with the cerebral venous thrombosis, and also low molecular weight heparin is also as good option in patient compared to the unfractionated heparin. And the COVID-19, we have seen a lot of venous thrombosis with COVID-19, and that should not stop you, again, according to the guideline, from vaccinating those people, because there are many people who are worried about the thrombosis with such patient, and also with cerebral venous thrombosis and the vaccination, and whatever has been a huge discussion about the type of the vaccine, whether it's Oxford vaccine or any type. I think at the end, everyone should get vaccinated, because we don't have any standardized study to show that there is a thrombosis which is higher than unusual with people who is receiving vaccination. And then we had our last but not the least, the session with epilepsy, and we heard from Dr. Maher about the psychogenic non-epileptic seizure and the way to differentiate between the two, but actually, and again, how you differentiate between the two. And probably Bern is actually one of the things that you have to look for those people. It does have psychological impact, and it's a conversion disorder. It's not actually, it's those people, they need to be approached. And you agree, Dr. Maher, they need to be approached by a psychologist or a psychiatrist. There is probably a rule of the SSRI. Interestingly, most of those people actually with psychogenic problems, they do have also true seizures. So good luck to differentiate the two, and maybe you can use these biomedical things and use the area of EEG. And then Dr. Mohammed Ashkanani, he spoke about first onset seizure. Do you treat or you don't treat? Maybe we should not, if there is no anything that push you to treat, like an EEG abnormality or a family history or any brain imaging tell you about the seizures, or maybe very long seizure. And this is something you have to put in your mind. And the why we don't, because probably the risk probably at the end is the same, and you probably will avoid the side effect profile. And at the end, it's case by case, actually, which one you decide. And if you are in trouble, and if you are lucky like me, and we have really a good epileptologist here in Kuwait, Maher and Ahmed Fawaz and Dr. Abdul Rida and Dr. Mohammed Ashkanani. I hope I'm not missing out. Those are an excellent people around, so they can help you with these medications. And last but not the least, Dr. Abdul Rida Al-Ghalaf, he told you today about what to choose in terms of medication. As you have seen in his graph, the treatment has been exponentially grown actually in the past few years or past decade. And that's probably something, is it good or it's not good? Actually, I think I heard one of the presentation before, is that's growing is very good or not, because there are lots of the old medication, they are still good also, and they are available and they are cheap. So you have to use them. You have to be ordered during a pregnancy. You have the levetiracetam for people, and probably the safety profile is good with this drug. Lamictal has very good safety profile also. And he told us about the elderly people, if they have a seizure, so you have to be worried about their liver enzyme and the renal function, and which one is actually avoid the renal. He spoke about pregabalin and neurontin in such people and when to stop if there is nothing to, and there are 2 years, maybe you can stop of everything. And again, is actually if you have a standard, I think what helped Kuwait really a lot having epileptologists, and we did have actually for the past 10 years an EMU with my great friend and colleague, Dr. Maher Arabi, establishing this unit, and my friends also, then Mohammed and Abdullah came, and I think Dr. Fatma Al-Gala. There are a very good actually epileptologist team actually, and we do speak to each other and to take a decision. I think there are the neurology is big, becoming big, and you cannot cover everything. So there are people who cover stroke and epilepsy and MS. So that's what we have been trying to cover in the first day. We're gonna see you again tomorrow at 9 o'clock again. We with an excellent speakers again, covering other topics, movement disorders, demyelinating disease, and we don't miss actually the neuroradiology sessions, because that will be an excellent also session from from our colleagues, and movement disorder, as I said. So without further ado, and really, I'm really thankful for you for being late with us and being a great, exceptional audience staying with us till this moment on a Friday afternoon, and till tomorrow. Goodbye.